Our chairpersons, I would like to call on the stage Professor Dr. Ravikant sir to give them a memento. I'll call the name. Sir R.S. Das sir. Professor R.S. Das sir. Professor D.K. Shukla sir. And finally, Dr. Altaf Mir sir. I'd like to thank you all for your auspicious presence.
Thank you, ma'am, for your presentation, which has cast a brilliant light on the topic, leaving us better informed and inspired. With sincere appreciation, we applaud your contribution. Thank you. For the next session, we would like to call the chairpersons on the stage, and the chairpersons for the next session are Dr. Mukul Sharma, Assistant Professor, Department of Forensic Medicine, Dr. Ananya Soni, Associate Professor, Department of ENT, and Dr. Mukesh Shukla, Associate Professor, Department of Community Medicine. Embarking upon this academic feast, we extend our esteemed welcome to the next voice of the day. With a great honor, we invite our next speaker, Dr. Ankit Gupta, Assistant Professor, Department of Cardiology, to come to the stage for his presentation. Thank you, sir.
I'm privileged and honored to be chairing this session, and I would extend congratulations to Department of Medicine. And there is no more introduction required to Dr. Ankit, as he is one of the assets for AIIMS Raebareli. After his joining, many of the consultants have showed a lot of interest in sending the patients, and very good reviews have been given by the patients for his work. So I would like to welcome Dr. Ankit to give the presentation.
Thank you so much, Dr. Mukul, for his warm words. Very good morning to all. As a co-organizing secretary, I welcome you all in the midterm annual CME, organized by our Department of Cardiology and General Medicine. So my today's talk is on resistant hypertension and its approach to its management. So, as we all know, hypertension is the most commonest health issue in our country. It is causing over 1.6 million deaths annually, and it accounts around more than 10% of the total mortality in our country. So, and it is being classified as high normal stage 1 to isolated systolic hypertension by the latest guideline of International Society of Hypertension in 2023. So there are various type of hypertension. We all know with according to the range of the hypertension, as with the primary hypertension, which is now the new term for the essential hypertension, secondary hypertension, isolated systolic hypertension, and resistant hypertension. So talking about the resistant hypertension, pseudo-resistant hypertension, apparent resistant hypertension, and pseudo-resistant hypertension and resistant hypertension. So in the absence of the confirmatory test, the resistant hypertension is defined as the blood pressure measurement above the target goal of the blood pressure. If it is used, if we are using more than equal to the three drugs, which should be of different classes, that is more important, and it includes one diuretic. Or if it is we are using the more than four different classes of the antihypertensive drugs, and it is being controlled, so it is called as resistant hypertension. So know the pseudo resistant hypertension, suboptimal blood pressure control secondary to the medication, non-adherence, white coat effect, or the poor measurement technique. Apparent treatment resistant hypertension, the cases in which the patient meets the criteria of the resistant hypertension but have the unverified adherence or medication, or have not undergone through the blood office pressure monitoring to rule out the white coat hypertension. So here is the a study by Bhatt et al. It was estimated the prevalence of most commonest cause of the pseudo treatment resistance is the medication non-adherence, white coat effect under the treatment, under antihypertensive treatment, and even there is a inaccurate blood pressure measurement. So we should know all the correct method of the measurement of blood pressure, which is been showed and beautifully in this picture. The patient should be sitting with the quiet room, comfortable temperature, resting before the 3 to 5 minutes resting before the blood pressure measurement, and there should not be any drug effect. Regarding the prevalence of the resistant hypertension, there are various studies has been done in all over the world, but still the true prevalence of the resistant hypertension is still unknown. But there were various clinical trials which suggest that it is near about varies 10 to 30% of the hypertensive patient in general population. It is a large cohort study which was published by Solani et al., which clearly revealed that the resistant hypertension, which is approximately prevalent to 15%, and it is strongly associated with the age, female gender, and smoking habits, and it has a strong independent association with the micro and macro albuminuria and eGFR less than 60 with advanced retinopathy. So we already know there are various causes of resistant hypertension that is may be related to the substance abuse or the drug like antidepressant, glucocorticoids, various hormonal contraceptives, and even there are various secondary causes of the resistant hypertension or the pseudo-resistant hypertension. There's a strong relationship between the hypertension and the diabetes. as the hypertension is present in more than 50% of the patients with diabetes and contributes significantly to both macro and micro vascular diseases. So all the cardiovascular diseases, the events are more 4 times, that is more than 4 times of the higher than in the patients with both having the both diabetes as well as the hypertension compared with the normotensive patients. Or moreover, the diabetes and the hypertension is strongly associated with several pathophysiological mechanism leading to various severe micro and macro cardiovascular diseases. So we should all need to maintain the blood pressure on a diabetic hypertensive patient below the 140 to 140 by 80 millimeter of mercury. Hypertensive diabetic patients are more prone for the cardiovascular diseases as it accelerates the atherosclerotic process and leading to various macro and micro diseases. Similarly, the endothelial dysfunction, vascular inflammation, vascular fibrosis, and arterial remodeling, that all leads to the macrovascular diseases in diabetic and hypertensive patients. These all pathophysiological mechanisms are responsible for the resistant hypertension, and that makes the clinical situation associated with the difficult to control the blood pressure. There are various antihypertensive agents. We already know that AC inhibitors, ARBs, diuretics, thiazide-like drugs, diuretics, mineralocorticoid receptor inhibitors. So now coming on to the approach for the management of resistant hypertension, we all need to know, first we need to exclude the resistant, that is the first step of the management, and thereafter we have already discussed that which about the pseudo-resistant hypertension. Now the second approach is to identify and reverse the contributing the lifestyle factors and discontinue the or reducing the interfering substances, screen for the secondary hypertension, thereafter give the pharmacological treatment in the fifth step, and if it is still not controlled, then you need to refer it to the specialist for the further intervention, because the patient may need any intervention also. So there's various recommended steps in the management of the resistant hypertension in diabetic patients to improve the lifestyle changes, to evaluate the adherence, exclude the pseudo-resistant hypertension, recheck the secondary causes, optimize the pharmacological therapy, and consider for the new strategies like RDN, that is renal sympathetic denervation. The early diagnosis of the resistant hypertension is the key of the treatment that includes the appropriate lifestyle, which and the antihypertensive drugs like diuretics, AC inhibitors, or beta blockers, or in case of patient with obesity or the metabolic syndrome. The fourth class of the drug of choice is the spironolactone. The approach to the resistant hypertension in diabetic patient is to screen all the diabetic patients for the hypertension, assess the blood pressure control and the adverse effect on follow-up. First, consider for the three different class of drugs that includes the AC inhibitors, ARBs, or calcium channel blockers, and the diuretics. So first, then again, we need to reassess the blood pressure on the follow-up. If the target blood pressure is not achieved in three different drugs, then we need to consider for the fourth class, that is more mineralocorticoid receptor antagonist. If it is still not controlled, then we need to go for the intervention. So lifestyle modification, we have all, this is the most important step which we all always overlooked. So reduce the salt intake, increase the consumption of the fruits and vegetables, low fat dairy products, increasing the physical activities and avoiding the alcohol consumption. Now coming on to the de-innervation therapy, resistant de-innervation therapy. New strategies for the management after the pharmacological therapy. So de-innervation therapy is basically based on the sympathetic cut down of the renal nerves. So the various technologies is based on the ultrasound radio frequency, or even the injection based, alcohol based. These are the latest technologies which we do for the renal de-innervation therapy. So the device based therapy to treat the hypertension damned after the result of the Simplicity trial. That was a landmark trial. Then again, the new trials has been emerged, giving the significant positive data on the control of resistant hypertension. That is the spiral hypertension on MED, Radiance, which solo or trio trials. It is the latest study published in JACC in 2020, which reduced hypertension reinforced, which basically give the significant positive result at 6 months, in which more than 50% of the patient showed the office and ambulatory blood pressure reduced significantly with the renal de-innervation therapy. Now still the question remains same, that whether it is effective or not, because there are various studies which shows various limitations in their study. Another new technology is for the management of the resistant hypertension is BAT, that is baroreflex activation therapy, which actually inhibiting the sympathetic nervous system and enhancing the parasympathetic nervous system. So here is barotism is a device which we use for the baroreflex activation therapy. There are various some new drugs also which are on trial, like non-steroidal mineralocorticoid receptor antagonist and double endothelin receptor antagonist, which may give promising effect on resistant hypertension in future. So in the last slide, the patient with a resistant hypertension should be screened for the reversible causes first, such as renal artery stenosis or primary aldosteronism and the obstructive sleep apnea. There are various. We should counsel the patient for the lifestyle modification, and spironolactone in a low dose even can improve the blood pressure in the resistant hypertension even. Thank you. Anyone want to ask anything? Yeah. Yes. Yes, sir.
Chronomedicine and chronobiology. So there are some patients which are night dippers, night non-dippers. So like in the BP, if like normally medications are given in the morning, early morning, usually most of them. So is there any, like, in some patients, there might be some non-dippers where the blood pressure doesn't come. So can we give the medicines at night or at night time? Like, are there any patients like that? Or
Yeah, we medications at evening also, like in diuretics, because it acts very slowly. So we give usually in the evening time so that they can sleep normally, because whenever we sleep there is a overload, and that causes everything, the sympathetic activation, overload. If the patient is symptomatic, then it is all about the sympathetic nervous system activation. So whenever we sleep at night, there is a overload that increases the sympathetic system in a patient who are already known case of the resistant hypertension or hypertension, or any other disease which atherosclerotic diseases, or any cardiomyopathies, that can be a hypertensive cardiomyopathies or coronary, because of the coronary.
what about the ambulatory blood pressure monitoring is being done?
Yeah, we usually do the ambulatory monitoring the 24 hours, which we see that there is a night dipping of the blood pressure, and that is the that gives the little bit of that for the diagnosis only, not for the management. It is only for the diagnosis. In a masked hypertension, sometimes we do the even the exercise test. That is every most of the persons knows that the TMT is used for the coronary. It is not only for the coronary. It is to diagnose the hypertension also.
So just to add to what Dr. Ankit has said regarding the chrono medicine and chronobiology. So there was a lot of hue and cry few years back, 4 or 5 years back, that if you give antihypertensive in the evening, the blood pressure will be very well controlled. But the clinical trials have, already proven that there is hardly any role of giving antihypertensive solely in the evening. So now the current practice is you can prescribe antihypertensive with respect to the time. So, but then identifying the non-dippers is equally very important. For that, you definitely have to depend on the ambulatory blood pressure monitoring. And in fact, it has become almost a practice of today to, before escalating the antihypertensive therapy, you must apply ambulatory blood pressure monitoring just to document as to how blood pressure is behaving at the time. So time is gone when you are taking a single reading and escalating the dose of antihypertensive.
Yeah, yes, sir.
And even before embarking on that this is resistant hypertension, I personally believe that adequate time should be given for the effect of the drugs to come.
Yes, 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 sir,
Thank you.
definitely.
It is a very good presentation.
Want to see this one? Yeah. Actually, there is you want to ask the mechanism? Actually, there are some baroreceptors which are present in the carotid sinus on the aortic arch. So that basically is supplied by the ninth cranial nerve that activates the cardioinhibitory center and vasomotor center. So basically, it inhibits the sympathetic system and enhances the parasympathetic system by accelerating the activation of the sinus, carotid sinus only. We place the device in the like a pacemaker only. It also helps in the patient with the heart failure. It is already approved for the heart failure patients. It acts like a CRT device for the synchronization of the ventricles.
Thank you.
Thank you so much.
Thank you so much, sir, for such a wonderful talk on resistant hypertension and diabetes. I would like to request our chairpersons to come on stage to felicitate our speaker, Dr. Ankit Gupta, sir, with memento and certificate. And to felicitate our chairpersons, I would like to request Dr. Rajiv Verma, Assistant Professor, Department of Medicine, to come on stage. Our chairpersons were Dr. Mukul Sharma, Dr. Ananya Soni ma'am, and Dr. Mukesh Suklas. Let's continue our learning expedition. And for the next session, I would like to call on stage the chairpersons, Professor Pragati Garg, Professor and Head of Department, Department of Ophthalmology, Dr. Danishwar S. Patale, Associate Professor, Department of Blood Bank and Transfusion Medicine, and Dr. Sachidanand, Assistant Professor, Department of Pharmacology. Let's extend a warm welcome to our next speaker on the stage. The talk is on Generation 2 insulin in clinical practice, initiation and intensification. I would like to request Professor Pragati Garg ma'am to come on podium to introduce our speaker.
Good morning, everyone. I'm happy and honored to be a part of this conference as a chairperson. I'm really happy to introduce a very dynamic speaker of this session, Professor Ravi Kant, who has a remarkable academic career. Presently, he's working in Department of Medicine, AIIMS Rishikesh, and he has got to his credit Himratan Award, Best Researcher Award, and also awarded with various prestigious fellowships both nationally and internationally. And he has got number of publications both in national and international journals. So I would like to invite Professor Ravi Kant. Sir, dais is all yours, sir.
Thank you very much, madam, for a nice introduction. I'm really very happy to be here and honored to be here on the dais. So the topic which I'm going to discuss in the next 25 minutes is generation 2 insulin and its clinical use in the real world situation. So my talk shall be revolving around how to consider insulin in type 2 diabetes mellitus, that is specifically generation 2. And what are the reasons to choose generation 2 basal insulins? And of course, art and science of basal prandial insulin intensification approach, how to go about managing our diabetic patients in day-to-day life. So what is the scenario of control of diabetes in India, or anyway in developing countries like ours and in countries like low and middle income countries? We are not able to achieve 20% patients who are well controlled with diabetes mellitus. That is to say, HbA1c less than 7% is hardly achievable in Indian scenario. And to be very frank, the percentage is not more than 12% in Indian scenario. We are not able to achieve HbA1c of less than 7. So definitely there is an unmet demand to basically intensify the treatment armamentarium. And the out of 5, you say 4 people are not within the range. This definitely predisposes for a plethora of complications or micro and macrovascular complications. So earlier and appropriate intervention may improve patients' chances of reaching the goal. So if you look at the OAD, combination of OAD as monotherapy, dual or triple combination therapy, and if you incorporate insulin, you'll find that the chances of achieving normoglycemia, that is HbA1c 11 less than 7%, is quite possible with insulin basically, which is not achievable by 1, 2, or 3 or combination of these anti-diabetic drugs. The people experience prolonged periods of poor glycemic control, which is detrimental to long-term outcomes basically. And of course, patients remain in poor glycemic control for more than 7 years before intensive treatment with insulin therapy. This is a legacy effect. Anytime during course of treatment of diabetes, if a patient is well controlled, he or she is predisposed to lesser amount of complications anytime in the life after even the glucose becomes uncontrolled. So this shows if you have a better control of diabetes in the early or the initial phases of the development of diabetes, the chances of developing complications are really very less in this population. So there is 24% reduction in the microvascular complications, 15% reduction in the MI, and of course 13% all-cause mortality is reduced if you achieve HbA1c less than 7 in the early course of the development of diabetes mellitus. Now, when to consider insulin in type 2 diabetic patients? Of course, increased HbA1c is one area where you have uncontrolled HbA1c for more than 6 months, and patients is already on dual or triple anti-diabetic drugs. The early manifestation of diabetes-related complications, the elderly patients who are having sarcopenia, cachexia, or chronic infections, of course, are a candidate for insulin. Subgroup with severe insulin deficiency, and these are the patients who are young, lean and thin patients. And symptoms of high blood sugar, that is patients who are having weakness, or in short, we call these patients insulinopenic patients. These patients, benefit a lot. A patient who is diabetic and complaining of weakness all the time, please put him on insulin. It's anabolic hormone. He will feel better. Anti-diabetic has nothing to do. A patient who is diabetic has got erectile dysfunction. This is an absolute indication for insulin. Even when the patient is having well-controlled blood sugar, this is one of the indications. Patients with dysautonomias, so they are some areas where you really need to look and ponder upon to start the insulin well in time. Now, when should we look beyond OADs for managing type 2 diabetes mellitus? Definitely when lifestyle modifications are largely failed, HbA1c above target, even on 3 OADs. OAD class should include 1 sulfonylurea, the metformin, third may be anything. And then comorbid conditions causing hyperglycemia have been ruled out. Say, for example, a patient is not taking steroids, or patient doesn't have a chronic infections, or something which is leading to a high blood sugar. Or patients separately, OAD failure can be defined as development of insulinopenic signs and uncontrolled glycemia in spite of using triple OAD therapy. So they all are the indications. So what is the role of these 3 oral anti-diabetic drugs? It has been seen that there is hardly any benefit of adding third drug or more than 3 drugs to the treatment of diabetes. So there is hardly any benefit of adding 4th drug in the treatment of uncontrolled hyperglycemia. It hardly brings down the HbA1c to the target. So this is the reason why we keep 3 drugs as a benchmark for calling that this is a uncontrolled hyperglycemia or OHA failure. And we see that as the fasting blood sugar is rising, HbA1c is also rising. So by virtue of fasting blood sugar, doesn't mean that it is only fasting blood sugar. It is the blood sugar which the patient is experienced throughout the night. It is just a screenshot, a snapshot of what the patient has experienced throughout the night. And that is the importance of fasting blood sugar. So fasting blood sugar is a very strong predictor of high HbA1c, number 1. Number 2, higher rates of complications, be it macrovascular complications, because patient is remaining in this state for a pretty long time, maybe 12 hours, 14 hours, or 10 hours, whatever amount it may be. The holistic glycemic approach is you need to first control the elevated hyperglycemia. That can be controlled. Your fasting blood sugar has to be controlled with basal insulin, that is long-acting insulin has to be given for controlling. It has been seen that the moment you control the fasting blood sugar, the excursions, that is postprandial excursions, are also controlled. So the dictum is you have to fix the fasting first. You need not embark on the postprandial hypoglycemia. You should not consider postprandial hypoglycemic control. Please go for the control of fasting blood sugar first. Once this is controlled, then only you divert attention towards the postprandial hypoglycemia. Until then, please be patient. Patient may be impatient, sir, my sugars are not controlled. But your approach is very meticulous and straightforward. I have to control the fasting first before embarking on the postprandial hypoglycemia. Treating fasting hyperglycemia lowers the entire 24 hours glucose profile, including postprandial glycemic excursions. At the same time, the practical aspect is ask the patient to moderate the diet so as to control the postprandial hypoglycemia. I'm pretty sure that with this regime, most of the patients, they do get control. Now we have pre-mixed insulin, we have basal insulin, that is lock-acting. Pre-mixed insulin is rarely or hardly used these days, except for some, situations. So definitely the basal insulin regimen are considered to be simple and flexible. They lower the risk of hypoglycemia and they have better treatment satisfaction so far as the patient quality of life is concerned. Now, how to initiate and titrate basal insulin therapy? The dictum is please start with 10 international unit or 0.1 unit to 0.2 units per kg per day, preferably at the bedtime. But it's not only bedtime, you can administer any time of the day, whatever the patient is feeling comfortable. Now, how to go about? Monitor the fasting blood glucose daily to titrate the fasting blood sugar. The dictum is fix the fasting first. So once you have targets reached, that is 100 to 130 milligram per deciliter, which is the most appropriate blood sugar for diabetic patients, then you go for the dose titration. How to titrate the dose? Once a week or twice a week, you can increase the basal insulin, to the patient, maybe by 1 unit or 2 units, depending on the comorbidity of the patients. And intensification, for intensification, you need to monitor PPBG. Now, fasting blood sugar job is done, which is basically controlled. Now you look at PPBG levels once fasting blood glucose target is achieved and add bolus insulin if it is required. If it is not required, please be considered about the continuing this regimen for 3 months and then reevaluate the patient by HbA1c and more. So what the ADA says? If the HbA1c above target, add basal insulin. Choice of basal insulin should be based on person-specific considerations, including cost. So a cost, constrained countries like India and other low and middle income countries, we need to embark. We have trials on NPH, which is, cheapest insulin available, which is equally efficacious. So add basal analog or bedtime NPH insulin, set the fasting blood sugar target first, choose evidence-based titration algorithm, increase 2 units every 3 days. So in a week, you can't increase by more than 2 times. And the days should be fixed. Like in our diabetic clinic, we say, increase the dose on Sunday and Wednesday. And don't touch in between. Don't do anything to the insulin. Then for hypoglycemic determination, you need to determine the cause. If no clear reason, lower the dose by 10 to 20%. Once you find there is no reason for hypoglycemia, dose reduction should be done. The titration period is definitely 12 weeks, that is 3 months, and maintenance period is after 12 weeks are over. So you need to reassess the patients on a continuous basis. The titration period is often defined as a time frame of up to 12 weeks following the initiation or switch of basal insulin to. Yes, so this is glycemic response during 12 weeks and after 12 weeks, therapy is a predictor for mid to long term glycemic control. So if you achieve the glycemic control early, the later on glycemic control is also better. So there is no need to wait for the, OADs to fill. If you ask me a simple question, who are the candidates for insulin therapy? The answer is all diabetic patients. All diabetic patients are potential candidates for insulin therapy, provided they are fully motivated and they are ready to take it. Factors that contribute to titration of inertia: reluctance by the healthcare provider, the patient or the both, they are reluctant to initiate the insulin. The issues of weight gain, fear of hypoglycemia, effect of insulin therapy on quality of life, lack of education, complex titration algorithms, lack of constant self-glucose monitoring, and of course, lack of flexibility. But these regimens are quite flexible. I mean, the patients can very well do it himself. So the AD recommendations for insulin titration: once the basal insulin therapy is initiated at 10 units per day, titration should be performed every 3 days or 2 times a week. Intensification is somehow it is done by increasing the dose of the basal insulin and by adding the bolus insulin once the fasting is fixed. If the patient is somehow not adhering to this regimen and there are erratic blood sugar and you feel that pre-mix could be a better choice, then definitely switch over to pre-mix insulin. There is hardly any constraint to it. So how the patient should be monitored after the patient has been titrated? If the blood sugar is as an 80, reduce the dose by 2 units. The goal is between 80 to 130, and every 30 milligram per deciliter increase in blood sugar should increase the insulin dose by 2 units. That is how the active titration period is all about. Now, when we should consider adding prandial insulin, once the fasting is controlled, this is the time if you feel that the prandial sugars are high, please do consider bolus insulin or short-acting insulin in this patient population. Now, what are the advantages of basal prandial intensification? The mitigation of PPVG excursions are definitely there. Dose titration of both basal and prandial insulins are required, can be increased in a stepwise manner, and there are, of course, few hypoglycemic episodes. So this is the evolution of basal insulin development from first generation to second generation, the time frame basically. So now we have classical first generation insulin, that's insulin Diabetic or IDEC and Glargine, and we have second generation insulins, that is U300. Earlier insulins were basically U100, but these insulins are U300, that is a smaller quantity of insulin contains more concentration of insulin. So what are the benefits and how to use them? So the new generation insulins, they have low risk of nocturnal hypoglycemia as well as any time of the day, less glycemic variability, lesser injection force, stable and prolonged PKPD profile and dosing flexibility of 3 hours. So they can take, this side or that side 3 hours. The flexibility was not much with the earlier insulins. Significantly lesser weight gain and definitely available as both disposable and reusable pens, which is patient friendly, definitely. So what are the points which are basically better with the Glargine U300 versus Diabetic U100? This is the older generation insulin, first generation, and this is the second or new generation insulin. So you can say bright study has already shown there's a powerful incomparable HbA1c reduction with Glargine 300, and the efficacy is as good as the earlier generation insulin, both titration. There are lower incidence of any time in nocturnal hypoglycemia Glargine 300. So this is best suited for those patients who are at high risk of hypoglycemia, so for example, geriatric population. So nocturnal hypoglycemia, that is midnight to 6 a.m. is less with newer generation insulin. And if you look at the continuous glucose monitoring profile, you will find that the time in range and time below range, that is time below range, sugars are maintained well below the range that is less than 70 or maybe 60 milligram per deciliter. This is remarkably less with the Glargine U300 and a highly significant p-value, you can say that. So, and similarly with the flash glucose monitoring system, time in range, that TIR or time in range of Glargine 300 versus IDEC 100, definitely is better with the U300. So real world experiences, this is RWE, real world experience in adult type 1 using CGM, Glargine 300 versus IDEC 100. Definitely they are preferring this new generation because of lower chances of hypoglycemia. So the time in range profile of Glargine 300 versus IDEC 100, if you look at the AGP, whole day period 24 hours, this similar time in range, time above range, or time below range profile between Glargine 300 and IDEC 100. In the night period, differences favoring Glargine 300 for time in range because they have lesser potential of hypoglycemia as compared to first generation insulin. So just to summarize my talk, the basal insulin is recommended as the most convenient initial insulin regimen and can be added to the metformin and other oral agents. So systematic yet patient-friendly dose up titration strategies with basal insulin helps achieve glycemic control. Generation 2 insulins possess a lower risk of hypoglycemia in high-risk populations. Even at high HbA1c, that is more than 9.5, basal insulin is effective and well tolerated in insulin-naive Indian patients with type 2 diabetes with a lower risk of hypoglycemia as well as weight gain. Glycemic control is imperative to reduce mortality in other complication of diabetes and hospitalized patients with hyperglycemia and otherwise OPD patients as well. Generation 2 insulin provides a right balance of efficacy with low risk of hypoglycemia, especially in patients who are prone of hypoglycemia like geriatric population and otherwise patients who are in multiple comorbidities. With this, I thank you all very much for patient listening. Thank you very much. If there is any question, I will be happy to answer.
Nice presentation, sir. Myself, Dr. Nilesh. I would like to ask, there are two questions. One is your short comment on insulin resistance. Is there any entity? And when we defined insulin resistant? Second, the patient asked when we have to shift from the insulin to oral hypoglycemic agent. Is there any concept or we have to put the patient lifelong on insulin if they didn't respond to previous oral hypoglycemic agent?
Okay, so I'll take up your second question as the first question. So ideally speaking, if you ask me a single question, who are the candidates for insulin therapy? Definitely all patients are candidates of insulin therapy. Why? Diabetes mellitus is not a metabolic problem of glucose homeostasis. It's a problem of insulin secretion or action by pathophysiology if you go by this. So any diabetic patient is definitely a candidate for insulin therapy, number one. Number two, you have to ask yourself, for what indication did I start the insulin? Was it infection? Was it surgery? Was it acute hospitalization? Was it an acute complication of diabetes? Or second is, can I shift this patient back to OHA, right? Say, for example, there are periods when you like to have, insulin being given for a shorter duration of time. So, for example, if you ask me, what are the absolute indications of insulin therapy? Definitely one is GDM. Second, patient is in any acute complication, be it diabetic or unrelated to diabetes. Acute MI, diabetic patient, yes, definitely. Then perioperative, yes. So they are the indications. When the indication itself is coming to a halt, then you can shift the patient back to or anti-diabetic drugs. And definitely with the emergence of new cardioprotective and cardio-friendly anti-diabetic drugs, they are much, much better than this one. Second is regarding insulin resistance that you've spoken about. So insulin resistance, whether we are talking in terms of absolute insulin resistance or this is a relative insulin resistance. So I mean, what mimics insulin resistance and how to take care of the insulin resistance. So if you go by the pathophysiology, the muscle, glucose uptake is independent of insulin action. And that is the rationality why we say that every diabetic patient should exercise. So the pillars of managing diabetes are threefold. Number one-third sugar can be controlled with lifestyle modification. One-third can be controlled by exercises. And remaining one-third should be controlled by anti-diabetic, be it OHA or insulin. But what is happening? Basically, patients are being not in the lifestyle modification or exercise. That is why you have to increase the dose of OAD from 1 to 2, 2 to 3, and then ultimately requiring insulin. So if you say simply to the patient, say your dose or the drugs can be brought down to one-third, provided you are sticking to your lifestyle modification and exercise. And the pumps which are located on the muscle surface, they're upregulated by the exercise. So a patient who is exercising daily for 30 minutes a day has definitely a better glycemic control. This is the first thing that the insulin resistance can be broken down. And there are only few indications where we say the patient is having absolute insulin resistance. That is true. Patient is receiving more than 75 international unit of insulin, even when blood sugars are not controlled. So for that, you really need to find out a cause. What is the reason is why the patient is producing more and more sugars. Cushing's is there, or maybe secondary diabetes is there, something else is there. For them, you have to really see. But most of our patients, they are having no insulin resistance the moment they start exercising every single day.
Good morning, sir. So in one of your slides, you showed that the two long-acting insulins were compared by continuous glucose monitoring. So I just want you to throw a light on this device. What are the advantages and disadvantages? And why don't you see our physicians telling the patients to use more of this? Can you throw light on this?
Yeah, so we have CGMS with us, continuous glucose monitoring system, and we have AGP, that is ambulatory glucose profile, which is almost as good as CGMS. So we are largely using the AGP in our diabetic clinics, and we are installing these instruments to diabetic patients. Although in our setup, maybe any other government setup is quite cheap. In private sectors, they are quite costly, but it really helps convincing the patient. Once you have a graph, say your blood sugars are going high after lunch or maybe after dinner or after breakfast, the patient gets convinced very well. Otherwise, patients, they have become so smart and sometimes smarter than the doctors itself. They will put some excuses. Yesterday I went to some party, I had some sweets, that's why blood sugar is high. Or they will be too smart. So they will be restricting their calorie intake 2 days prior to going to lab. They will come out very fine blood sugar reports, fasting 100 and PP 150, 160. And if you look at the HbA1c, this is sky high, 9, 9.5, 10, 20.5, something like that. Where you suspect that there is a discordance between the day-to-day blood sugar, that is fasting PP, and long-term glycemic control, that is HbA1c. So they are the indication they should install the AGP to the patient. It's a very simple procedure. 2 minutes, you can install on the arm, and the sensor will continue checking the blood sugar from the flesh of the patient, and it will generate a graph for 14 days. And by that graph, you can convince your patient, say your all-time blood sugars are either high, or the indications are sometimes patients are going to nocturnal hypoglycemia. These patients do not know what is happening to them. If you ask them, they have very bad dreams. रात में सोते हैं तो बड़ी खराब सपने आते हैं, and they have very unusual dreams. So you suspect hypoglycemia in the night. You install the AGP, you will find that really the patients are going to hypoglycemia in the midnight. And the moment you bring down the insulin or OADs, the dreams are no more there, the hypoglycemia is well taken care. And third is patients who are type 1 diabetic patients, and they are having variable exercise potential, right? So on holidays they may not exercise because they are not going to school, they are not playing. Those days blood sugars goes high. Other days when they are playing, they may be having hypoglycemia. So they are indications for continuous glucose monitoring system, and you must give these patients to these devices to a patient. They really help in decision making, and of course, a shared decision making between physician and the patient.
So, very nice presentation. Yeah.
Really got to remember that first machines, those patches which we use, the 14-day patches, were actually, as per the guidelines, they were approved first for the GDM patients. It was actually approved for GDM and not for the other patients. That's why it took certain time for the physicians also start using them everywhere, like as a norm. But having said that, now as Mr. Ravikant has pointed out, it can be used first to convince the patient, and as well as to find out a lot of places like where you are having hypoglycemias, even for post-surgical patients where they have high HbA1c and the anesthetist is not really giving you clearance for the surgery. It's very easy, put the patch over there. Look, this is my sugar readings for the last 14 days for this patient. Come on, go ahead and operate. But there are few things that one has to remember. One is that you don't extend it beyond 14 days as per even the new ADA, the new guidelines. The second thing is this is an interstitial fluid which you are actually checking your sugars for. So you should not actually match it exact, mark to the venous or the capillary fluid. And third, there will be certain variabilities. For example, when you run, what happens? The interstitial fluid moves, shifts. So equally, the sugar readings also change. There are times when suddenly the patient will come, sir, I did not eat anything, but I just went for a run and suddenly my sugar appears to be higher. Why is that happening? That is because actually the interstitial fluids move and then the sensor will pick up a bit more. So you have to look at the graph, you have to see continuously, and in between you have to keep these things in mind. You have to tell them that these are the places where these readings can actually change. And that is why the authorities did not give clearance for long and had kept it only for GDM. So these are points that you have to remember.
And secondly, it shouldn't be used for decision making. For decision making, you have to go for glucose monitoring or maybe venous, because there is a lag phase between the venous glucose and the interstitial fluid glucose, approximately 15 to 30 minutes. So sometimes you might be experiencing hypo in the AGP, but in fact the blood sugar may be normal or may be high.
It's a very nice presentation. I'm a pediatrician, and basically I see mostly type 1 diabetes mellitus. I hardly have any experience about type 2. So I have a question regarding a very practical scenario that we face these patients. Most of the times these kids, they present in DKA, and once the DKA is taken care of, we put them on regular insulin for initial 2 to 3 days. Once we have a good estimation of their insulin requirement, then we switch to initially we used to use mixed starts and this regular and NPH, but the sugar control was very erratic. Nowadays, what we are using a basal bolus regime, where we give a night dose of glargine or lantus, and along with that we give a 3 8-hourly doses of regular insulin as per their requirements, physical activity, and dietary habits. But what problems that we face nowadays, that even after giving a single glargine plus these 3 regular insulin shots, still, since kids it's very difficult to get the dietary control, because you cannot put them a very strict diet regime. So many times when they come for follow-up, we always have very erratic sugar levels at times. So we need to fiddle with this regular and insulin plus glargine doses. So I just wanted to have your experience. How can we better this practice, or because in insulin pumps, again, they are very costly in our setting. People coming to IMSS regularly, they hardly can afford. So that is the best strategy that I'm following in between regular NPH and using a basal bolus with glargine plus R. But again, the sugar controls many times very difficult, especially because of this child's dietary behavior and their activities. So I just wanted to have a
very important and pertinent question so far as the pediatric patient is concerned. The issue is the patients, they are basically having hyperhypos. Typical type 1 diabetic patient, small child, will have hyperhypos. Why these hyperhypos are taking place basically? It is not only the patient or the child who is at fault, or in fact, this is the reaction of a mother to child's hypoglycemia. So the moment the mother sees hypoglycemia, she overfeeds, overcorrects hypoglycemia. Next time, the child will go into hyperglycemia. Again, some more insulins are being, poured into the subcutaneous tissue of the child. Then he will have hypoglycemia. So this is a classical picture of a hyper-hypo syndrome, basically. So we need to understand. So type 1, managing type 1 is very difficult, basically. But what is the key and cornerstone for managing type 1 diabetes? To develop a robust, support system, wherein a mother should not feel that she is, alone in the care of the child or type 1 child, or his own or her child. So we at Rishikesh, we are in collaboration. We have 300 children, type 1 children. So regular meetings, first Sunday, they interact with each other. They themselves are the role model for other diabetic patients, apprehensive mothers, apprehensive children who do yoga, who do deliver lectures. And this type 1 diabetic, we have named it diachamps. So they are involved in all type of, support system. And there is a group amongst themselves also. So some children may be 2 years or 3 years or 4 years more, but the oldest has already, become adult. So they are pursuing some higher degrees, and now they have become role model how to take care of a type 1 diabetes and long-term care model. The problem is, number 1 is education, number 2 is support system, and treatment. I must say that it is the last one. Sick day role is, of course, very important. The regular training or the regular training of the mothers or the caregiver of the type 1 diabetic mellitus is equally important. Pubertal spurt has to be really seen very cautiously, because this is the time, usually at the age of 9 to 11 years in females, 11 to 13 years in males, when there is, sex hormones coming into play, there is a rapid shift of glycemic curves. So there are some certain areas in long run, but short term, definitely sick day role and other, causes that you need to see for the hypoglycemia. Thank you.
Thank you so much, sir, for such an wonderful talk and igniting session. It was a beacon of enlightenment, and the insights that we have gained over this session will last longer than this session only. So to felicitate our respected Dr. Ravikant, sir, I would like to request all the chairpersons on the stage to felicitate him with a memento and certificate. Please put a good grand round of applause for him. And now to felicitate our respected chairpersons, I would like to call on the stage Assistant Professor Dr. Manu Sharma, sir. Professor Pragati Garg, ma'am, please give her a big round of applause. Dr. D. Patale, sir. And Dr. Sachinandan, sir. After this session, we will be having the inauguration program, so kindly be geared up for this.
सीट कहाँ चला गया? बंद करके दे रहे तो क्या है? Secretary, ask us. Very well. Very well. Very well. इसमें सब लोग आएंगे खाली पूरे पर्टिकुलर को ये तो ऑलरेडी सेपरेट इसकी फट गई इसकी छोटा लाइट देखो ना पेन साइंटिफिक चेयर क्वेश्चन है ना कार्डियोलॉजी सोसाइटी ये प्रेसिडेंट ऑफ कार्डियोलॉजी सोसाइटी साइंटिफिक स्पेशलिस्ट को लिखा है उसमें कितनी पेन है मुझे बाहर कर हो क्या अपने को इंट्रोड्यूस की जरूरत नहीं है शुरू करना है अरे हम कौन है अच्छा ठीक है क्या बोलोगे आनंद करते बोलते सीधा शुरू करो कुछ दिन भी पूरा नहीं है अपने को इंट्रोड्यूस करने की जरूरत नहीं है तो है करने की जरूरत नहीं है वो तो सीधा
Ladies and gentlemen, distinguished guests and honored participants, welcome to this momentous occasion. Now we gather for the next session, which is formal inauguration program.
Ladies and gentlemen, it is an honor to introduce our distinguished guests to grace this stage today. Please join us in welcoming our guests for this inaugural event. whose guidance and leadership have been instrumental in making this day a reality. I call upon the stage our esteemed chief guest, Dr. Arvind Rajvanshi, Director, AIIMS Raebareli, our esteemed guests, Professor Dr. Surekha Kishore, Executive Director, AIIMS Gorakhpur, who is absent today for some unavoidable circumstances, Professor Dr. Ravi Khan, Head of the Department, Department of Internal Medicine, AIIMS Rishikesh, and President, Cardio-Diabetic Society, Professor Dr. Neeraj Kumari, Dean, AIIMS Raebareli, Associate Professor Dr. Mukesh Bhairava, who is the Scientific Chairperson of the Cardio-Diabetic Society, and Assistant Professor Dr. Anirudh Mukherjee, Organizing Secretary of this CME.
We kindly invite all the esteemed guests and dignitaries to join us in the program for the Deep Prajwalan ceremony, where we'll collectively illuminate the lamp of knowledge and wisdom, symbolizing the beginning of the auspicious occasion.
Shubham Puratvam Kalyanam Arogyam Dhanasampada Shakti Buddhi Vinamsham Ekam Chotilamusute Ekam Chotilamusute Shubham Puratvam Kalyanam Arogyam Dhanasampada Shubham Puratvam Kalyanam Arogyam Dhanasampada.
With the blessing of Ma Saraswati, this moment brings us in a significant milestone in the realm of Cardio-Diabetic Society. Cardio-Diabetic Society is finally launching their first e-journal. This will pave the way for a journey of intellectual and exploration and enlightenment. I humbly request all our esteemed guests to join together to launch this journal.
Now I would like to call upon stage President of Cardio-Diabetic Society, Professor Dr. Ravi Khan sir, to address the inaugural session.
I would request our esteemed guests to formally inaugurate the occasion.
Now I would like to call upon stage President of Cardio-Diabetic Society, Professor Dr. Ravi Khan sir, to address the inaugural session.
Most respectful Director, AIIMS Raebareli, Professor Arvind Rajvanshi sir, Dean Academics, Madam Neeraj Kumari, Executive Director, AIIMS Gorakhpur, and Patron of Society, Professor Surekha Kishore, senior faculty members, colleagues, students, residents, officers of AIIMS Raebareli. Dear friends, ladies and gentlemen, I am so pleasured and honored by having this opportunity to be at AIIMS Raebareli. I really thank the highest seat of this institute, Director, Professor Arvind Rajvanshi sir, Dean Academics, for having given this opportunity to us to have some scientific discussion on cardio-diabetes. And in fact, this is an ongoing journey, and that journey that we began approximately 5 years back. So to brief about the society and these activities, basically there was an unmet need in India because there were so many societies: cardiology society, diabetology society, physicians forum, but they were, isolatedly doing their work. But if you look at the demography of the disease in India, the NCDs, the number of deaths by NCDs, basically diabetes, cancers, coronary disease, and you look at the 10 top diseases which are killing Indians as of today, diabetes, coronary disease are basically jumping from lower to higher magnitude. So that was the need for starting these societies activity. And in fact, there are 4 societies currently working in India on this combined approach of cardiology and diabetes. And we are exclusively working in North India. We are joining hands with the cardiodiabetic society so that more and more evidence generation can be done. At the same time, the INIs are a big potential. INIs are a big potential. We need to join hands with so many INIs, aims at various places so that we can come up with cost-effective guidelines for the treatment of the cardiac disease as well as diabetes. So not taking much of the time, I thank all the officers right from top and the young energetic team led by Dr. Anuj Mukherjee, Dr. Pramod, Dr. Manu Sharma, and other faculty members at Department of Medicine, along with their supporting hands to host this event. Thank you, Oliver. Thank you all very much. Thanks.
Now I would like to call upon stage Honorable Chief Guest, Professor Dr. Arvind Rajwanshi, sir, the Executive Director, AIIMS Raebareli.
Professor Rekha Kishore, Executive Director, AIIMS Gorakhpur. I am addressing her in absentia. Professor Ravi Khan, Head Department of Medicine at AIIMS Rishikesh. Professor Neeraj Kumari, Dean Academics, and Professor and Head of Department of Pathology and Lab Medicine at AIIMS Raebareli, and Professor Bharava, Dr. Pramod Kumar, Dr. Anirudh Mukherjee, my faculty colleagues, friends and ladies and gentlemen. At the very onset, I'd like to welcome all the faculty who has come all the way to participate in the annual midterm meeting of Cardiac Diabetic Society here at AIIMS Raebareli, and we are privileged to host them. And we are lucky that they are all be deliberating on the various issues. Dr. Ravi Khan said, non-communicable diseases or NCD has become part of the Government of India's thrust, even in the rural areas, especially diabetes, cardiovascular diseases, especially the hypertension and the cancers. We are lucky that we are deliberating upon 2 diseases, the cardiac as well as the diabetes. If you look at the pathogenesis, it's the first, the diabetes attack the body. And that leads to so many complications as it involves almost each and every organ, whether it's the heart, whether it's the eye, whether it's kidney, they're all affected by it. And when we look at the heart, the main problem with diabetes is myocardial infarction. That's one. Another is the hypertension, accelerated hypertension. And most of the people do not know that they are hypertensive. They are detected hypertension once they come to the hospital or the PHC or to go visit a doctor for something else. Then they are detected to be hypertensive. And diabetes, same thing. Once the diabetes is detected, it may not be detected otherwise because the body adjusts to the blood sugar unless it leads to a complication. It's very timely to deliberate upon it and to discuss these issues. I'm sure this conference will go all the way and make some recommendation about how to prevent the disease and how to treat it. Because a lot of advances have gone into the diabetes management and diagnosis, and same is true of the cardiac disorder. So I wish very good luck to all of you in your deliberations, in your discussion, and finally making a recommendation to us as well as to the government. Thank you very much. Jai Hind.
Thank you, sir. Now I would like to call upon stage Dr. Neeraj Kumari, Dean Academics, AIMS Raebareli, to address the program.
Honorable President of the Cardio-Diabetic Society, Professor Ravikant, our respected Director of AIMS Raebareli, Professor Arvind Rajvanshi, the dignitaries on the dais and off the dais, my faculty members and students. Very good morning and welcome to all of you. I have already had one interaction in the morning during my lecture, and I congratulate all the delegates and the Department of Medicine to organize this academic event. And I hope that I think we already have 2 or 3 lectures till now, and the academic feast, which is going to take place here, may help our students, the undergraduate students who are going to be the next intern, as well as the PGs, to enlighten their knowledge. Thank you very much.
Ladies and gentlemen, now we move to the token of love distribution to our esteemed guests. To do the honor, I would like to call upon stage Dr. Ravikant sir to give the token of love to our esteemed chief guest, Dr. Arvind Rajvanshi sir. Once again, I request Dr. Ravikant sir to give the token of love to our esteemed Dean, Professor Dr. Neeraj Kumari ma'am. I would like to request Dr. Neeraj Kumari ma'am to give the token of love to Dr. Ravikant sir. Due to some unavoidable circumstances, Professor Dr. Surekha Kishore ma'am, Executive Director, AIMS Gorakhpur, could not join us in person today. She is joining with us via online platform. I will request her to address this occasion.
Honorable Director AIMS Raebareli. Am I audible? Am I audible? Am I audible?
Yes, ma'am.
Okay, okay. A very good morning to all of you. At the outset, I would like to thank our Honorable Director, AIMS Raebareli, Professor Rajvanshi sir, and Dean Nirja Madam, Dr. Ravi Kant, and all the dignitaries on the dais and off the dais, the faculty members, students, residents, and all the people who are present in this August gathering. It is indeed a very proud moment for us to be here on the inaugural ceremony of the Cardio-Diabetic Society midterm CME, which is held at AIMS Raebareli. And I wish my best to all of you, and I congratulate the whole team led by Dr. Ravi Kant and the organizing team led by Professor Rajvanshi for holding this great CME at your institute. As all of us know that cardio diabetes is a major problem right now, and India is leading, one of the leading country in cardio diabetes, and definitely this is the apt moment that we create awareness as well as update ourselves regarding the management and prevention measures to be undertaken for this. And this workshop and CME would definitely benefit all our students as well as doctors and medical fraternity all over the country. And I congratulate Dr. Ravi Kant on this occasion as well as our director, sir, for holding and organizing this CME at his institute. And I'm really sorry and I really regret that I could not come in person to your institute. Till yesterday, my plan was there that I would be coming, but due to some reasons, I had to stay back. And I'm sure that in future, we are definitely going to have such workshops and CMEs at your institute wherein I can come over and be with you people physically. So once again, thanks a lot for giving me this opportunity. And I definitely miss this great event being physically present there. So I'm really sorry for that. And I really admire the efforts of the whole team. And congratulations and my best wishes for this CME. Thank you very much. Over to you, sir.
Now I would like to request Dr. Mukesh sir to give a token of love to Dr. Pramod Kumar sir. I would like to request Dr. Ravikant sir to give the token of love to Dr. Anand sir.
To conclude the inaugural session and provide vote of thanks, I would like to call on stage Dr. Pramod Kumar, sir, organizing chairperson, and Dr. Anirudh Mukherjee, organizing secretary of this program.
Uh, I didn't know that I was giving the vote of thanks. I'm so sorry, but I'm not prepared, and I'm actually very overwhelmed by seeing this August gathering. And first and foremost, I would like to thank the executive father of our institute, Professor Arvind Rajvanshi sir, who is like a father to all of us. He is the guardian of the institute, and this institute is daily thriving under his guidance. I mean, you just look at the picture of before and after. There is a marked difference. What we wear and what we are, there should be a big round of applause for that. Next, I would like to thank Dean Madam, who has always been like the biggest supportive figure in this institute, no matter what we want to achieve. I mean, I simply went to her and said, ma'am, I have been awarded we have been awarded the midterm CME of Cardio-Diabetic Society, and I'm extremely nervous. Ma'am, should I go ahead with it? She said, just go ahead and you will manage. I know. I am with you. Thank you. I'm really grateful. I'm really grateful to my idol in the medical field, Dr. Ravikant, who also happens to be the president of Cardio-Diabetic Society, for giving me this opportunity, for having this trust on me. I still remember during the annual conference in AIIMS Gorakhpur, I went to sir and said, sir, ये मैं भी कर सकता हूँ. Please, sir, आप हमको भी मौका दीजिए. तो I could not get a positive answer for at least 2 days. 2 दिन बाद sir gave me a call and said कि अनिरुद्ध तुम मुझसे भी अच्छा कर लोगे, मुझे पता है, you just go ahead. A round of applause for him also. I'm really grateful and thankful to Dr. Mukesh Bharwa, under whom I had done my senior residency earlier at AIIMS Rishikesh. I have learned a lot from sir. We started a relation as a teacher and student, ended up being elder brother and younger brother. Sir, thank you very much, sir. I would really like to thank all the organizing committee people. First and foremost, Dr. Pramod sir, who is my senior, and he has always guided me throughout to go ahead. I really trouble him with everything, with each and everything in the department, and he always says कि तुमको जो अच्छा लगे वो तुम करो. मुझे पता है कि तुम गलती नहीं करोगे. अगर गलती करोगे तो तुम्हें डांट भी पड़ेगी. And I am also really grateful to Dr. Professor Surekha Kishore Madam, under whom I have worked as a faculty at AIIMS Rishikesh, and I'm actually absolutely honored to give vote of thanks in a session where she is the guest of honor. It's an absolute privilege, ma'am. I really miss your guidance. I wish you were here today. I am really missing you right now, ma'am.
Thank you. Thank you. I am also missing you, all of you too. Next time, definitely I'll be there with you people.
Ma'am, please, I'll come there to escort you, ma'am. I really want you here once, ma'am. Ma'am, thank you, ma'am.
Sure. Okay, thanks.
And I would really like to thank all my juniors who are there in the Department of Medicine with me. I would really like to thank Dr. Mahendra Meena, who was my senior resident at AIIMS Rishikesh. He was working in JIMS Noida, and I really got after this life that you have to come here, you have to come here. It's a wonderful institute, you have to come here. And he did. Mahendra, thank you. I would really like to thank Dr. Rajiv Verma, who was my junior resident in KGMU when I was an SR in that unit, and I really got after his life also. कि तेरे को आना पड़ेगा. And Dr. Manu Sharma, who did his PDCC geriatric medicine under my guidance at AIMS Rishikesh and under the guidance of Professor Meenakshi Dhar ma'am. And he was working in Himalayan Dehradun. He was extremely happy with his job and all. But again, the same story happened with him. I got after his life again and I pulled him to this institute. Dr. Manu, thank you. I would really like to thank my good friend, Dr. Suesh Singh, who's the additional MS of the institute also, for always supporting us in every endeavor. Thank you, Suesh. I would really like to thank all my nursing officers, the nursing officer team who are there. I would like to thank my senior nursing officer, Dinesh, who really helped me out with all the logistics for this ceremony. And last but not the least, the most important of the most importance, I would really like to thank all my esteemed speakers. Dr. D. Himanshu, I have worked under him in KGMU. I have learned critical care under him. Sir has been my guide and sir has always guided me throughout and sir is still actively guiding me. Thank you, sir. I would really like to thank Dr. Vikram Singh. Sir happens to be the MS of RML also. And sir and me, we work together in a lot of social endeavors also outside the institute. Sir, thank you so much for being here. Sir is a wonderful orator. Just wait for the session. I am really grateful to Deputy Director Sir, Deputy Director Sir, S.K. Singh Sir, for supporting us with everything. And this institute is always full because of him. आपको जो भी चाहिए सब कुछ मिलता है. Thank you, sir. I would really like to thank my good friend Samir Shukla ji, who is the senior admin officer, for always guiding me throughout as a senior in everything, especially when it comes to government rules. I mean, we doctors are really naive when we join government services. We are not accustomed to government rules. I don't know what the hell was CCS rule. We have never heard about it. And sir has always guided me throughout. I have been pleading, sir, all throughout to hold a session of CCS rules for all of us. And also, I would like to thank, I just forgot his name. He would have gotten after my life later on. Ankit, thank you very much for holding the live workshop today. Thank you. I would also like to thank Dr. Smriti Singh, who has visited us from Allahabad Medical College. Ma'am also happens to be my Anomaline senior, and we also share the same guide from Himalayan. Ma'am, thank you. I can see Dr. Deepak Bhaktchandani, Assistant Professor, King George Medical College, Dr. Ambuj Yadav, Assistant Professor, King George Medical College, and Dr. Mehak Lamba, King George Medical College. Thank you so much that my friends are here. Thank you. And last but not the least, all my faculty colleagues who have always stood by me, who have always been there with me, all my professors in the institute, I'm really grateful to you. I'm absolutely overwhelmed. I don't have words. I'm so happy that all of you are here. I'm really grateful to you. Thank you very much for being here. All my students, all my residents. Thank you very much.
You all for this ceremony, and I thank you to Professor Ravikant sir, HOD Medicine AIMS Rishikesh. He is a president of Cardio Diabetes Society, to give us an immense opportunity of this conference. And I thank you to Professor Arvind Rajansi sir, our Executive Director sir. He already known about the Cardio Diabetes Society, and he has given to us a time for this session today. And we thank you to our Dean Ma'am, Professor Neeraj Kumari. She has given to time us for this session. And along with this, I thank you to all our esteemed speakers and chairpersons and our faculty member and my dear student and colleagues. And our nursing staff, and along with our administrative officer, Samir Shukla ji, and DJ sir. And lastly, I thanks to Mr. Arpit. He has given full IT support to us. And okay, thank you.
Now I request everyone to stand up for national anthem.
After such a wonderful inauguration program, let's move ahead with our scientific program. And as we delve deeper into the realm of learning, we'll go with the next session. The next session is on sepsis and diabetes, is recognition and management. And for the session, I would like to call chairpersons on the stage. The chairpersons for the sessions are going to be Dr. Mrityunjay, Associate Professor, Department of Pediatrics, Dr. Amit Misra, Assistant Professor, Department of Urology, Dr. Pawan Kumar Biswakarma, Associate Professor, Department of Medicine, Government Medical College, Azamgarh. I would like to request Dr. Mrityunjay sir to introduce our speaker for the next session.
Good morning, everybody. It's my proud privilege to introduce our next speaker, Dr. Himanshu D. Reddy. He's just back. So he's a professor and medical superintendent KGMU Lucknow. And he's in charge of infectious disease unit, Department of Medicine, KGMU, in charge of endogoiter unit and intensive care unit. He has more than 140 international and national publications, 20 book chapters, and more than 20 government-funded projects. He's in charge of ICMR Intent Clinical Trial Center Central Zone, and he has got multiple key researches in development of new antimalarials, HIV, diabetic and metabolic disease, and he has got multiple projects funded by various agencies under his name. So it's thank you, Dr. Himanshu, for coming to this place and giving this session for all of us. So over to you, Dr. Himanshu.
Thank you. It's my pleasure to be out here. And so I also thank Dr. Ravikant for giving me this topic. It's a bit different from what we usually discuss, and I prefer, having a discussion on this, a very important topic because, yeah, thank you. Sepsis, as we know, is one of the major issues that we always face. Why you want to control diabetes is, of course, to avoid the complications. Technically, if somebody asks you why did people come up with this value of fasting 126 and a PP of 200, why did somebody start saying that the sugar should be below this? So actually, technically, it is because beyond these sugars, in at least majority of the population, you will see either a retinopathy or a nephropathy or increased risk of sepsis. So that is how these values were selected. There are times when you will see patients who have higher values and still you won't find any complications, and there will be patients who will actually have complication even below this, but they are the outliers. Now, when we talk about sepsis, when they suggested this topic, we have to look at it in two different ways. One is why are diabetics prone for sepsis, and secondly, what do you mean by actually early sepsis markers? Now, early sepsis marker is something that you will be using every day. You talk about fever, you talk about ICU care, you talk about your emergencies. The first and foremost is you want to identify sepsis and you want to identify infective organisms if possible so that you can treat them. But by your own practice, it is not so easy. It's not so easy to identify. In many of the places, you'll have fevers with undefined origins, and there you'll be using certain factors to basically say that this patient is going into sepsis, I need to start antibiotics. Yeah. So why we are discussing this? Of course, we know that diabetes and sepsis are important for both morbidity and mortality. Now, if you're sitting in a diabetic OPD, then one of the most important things you will have is a recurrent complication. For example, recurrent UTIs, patient presenting with diabetic foot ulcers, patient presenting with in the emergencies with actually having pneumonias and all. And together they form a major chunk of both morbidity and mortality. And we also know that dysregulation of pathways, immune pathways, can occur both by sepsis and diabetes, and there is an interplay which leads to this. Technically, if you ask someone, if you look at this, diabetes, what is it actually? Well, both, yes, diabetes is an endocrine disease and diabetes is a inflammatory disease. How? Well, the sugars, when you have high sugars, there is glycosylation of different proteins. For example, you have that glycosylation of the collagen proteins, and that is why you have these proteins. Once there is glycosylation, they are actually recognized by the body's immune system as a foreign protein. And that leads to a micro-inflammatory process. That is what leads to both retinopathies, nephropathies, along with, of course, the microthrombotic features which occur once the inflammation occurs. This is also seen, I think we have another lecture by Professor Vikram where we'll be discussing about arthropathies also. That also is actually a component of the same thing. So similarly, what happens is when you have this sort of glycosylations, this leads to an pro-inflammatory cytokine state, and this pro-inflammatory cytokine state actually leads to endothelial dysfunction. On the other hand, if you look at the sepsis itself, whenever there's an organism which enters, for example, let's take a very simple example which everybody knows, that is a COVID. The virus enters, the virus instigates an inflammatory process, the process leads to a SIRS, and the SIRS, actually it is the death or the morbidity occurs because of the endothelial injuries, and the tissue injury finally leads to poor outcome. So technically, when you're talking about diabetes, you're talking about both the inflammatory and the hormonal thing. When you have very high sugars, as we know that, of course, there are different areas of the body actually are a very good media for the growth of organisms. You have a urine which has, for example, if you use high amount of SGLT2, we know that there is leakage of the sugars into the urine, and the urine itself becomes a very good media for the growth of organisms. So that is something which you can understand very simply if you understand this basic concept. Why does one have sepsis? Now, there is one simple concept, that is, why does one have sepsis? Sepsis requires two things. One is, of course, the malfunctioning of the immune system, and a very simple thing, breakdown of host barriers. Now, this looks like a very simple concept, but the thing is, we tend to miss out on that. I'll give you an example. In the past, I'll just share a case, how people think when they look at these sort of systems. I remember once when I was in my own ID, I was learning, we had a case of a patient who was actually having recurrent just tachypnea and tachycardia. There was no fever. But this was not explainable by anything. So then my ID consultant, he started searching for sepsis, and then they had anaerobic, medias, and the blood culture showed Clostridium sordeli. Now, Clostridium sordeli is an organism which actually stays in the gut and in the lower genitourinary tract. Now, the point is, for most of us, it would be good enough, having Clostridium sordeli, you would say, okay, I'll treat it. But then the next question is, why did the Clostridium sordeli enter into the bloodstream? So that's how I would think. And then they started searching for that. What did they find? There was a small mass in the rectum where there was a cancer, and the cancer had actually denuded the barrier, that is the mucosal epithelia, that led to the recurrent entry of the sordeli. So if you have a patient with diabetes where there's a breakage, where there is a milieu, and then if you think about it, if the patient has neuropathy, where the skin barriers are going to get actually broken down, then your chance of actually having sepsis is much higher. So why are diabetic patients at risk? We just discussed that one, there's vascular insufficiencies, there is peripheral neuropathy and insufficiency, and autonomic neuropathies, which lead to further damage and allows the organisms to enter. The peripheral neuropathy ensures that you have a patient who is not able to recognize the micro traumas. You have vascular insufficiency where there will be decreased blood flow, which leads to denudation, and you have vascular ulcers. And autonomic neuropathy ensures that there is retention of urine and all. So this depressed cell-mediated immunity and all these factors lead to an increased both barrier, increased chance of infection, and also an increased colonization of different organisms. Why this is important? Now think about it. Suppose you have a patient who has an colonization with Staph aureus in his mucosa of the nose, then the chance that whenever the patient scratches, he will most probably actually leading to an entry of the infection, and that increases the risk of sepsis. Similarly, the patients with diabetes tend to have colonizations with Candida, like Candida albicans and all. We know that they tend to have asymptomatic bacteriurias and asymptomatic candidurias. So the moment there is a small breakage in the barrier, these patients will develop sepsis. Then, of course, there are certain factors which you also have to remember. For example, certain organisms are prone to infect in diabetic patients. The best example is mucor. Wherever you have high sugars, the ketone, for example, a patient who has diabetic ketoacidosis, then after that, the chance of development of mucor is much higher. And this is what you saw even in the post-COVID era, when you had the mucor epidemic, where this was happening because of the high load of sugars, which occurred because of the increased use of steroids. So common infections which we know about are all upper respiratory, lower respiratory tract infections, periodontal infections. Now, periodontitis is something you have to remember has now been for many classified as a microvascular complication of diabetes. If you ask a dentist, he will tell you one thing, that if they see a periodontal disease, they usually go backwards and do sugars. We tend to forget upon that part. What happens? The gum, the bone next to the tooth, there is decreased supply because the small capillaries have microthrombi, due to which the bone starts actually having resorption. Once there is resorption, then there will be gaps between the tooth, and then they will start getting infected. So by and large, if you look at the dental teaching, if the patient has a periodontitis unexplained, then one should immediately go back and do the sugars. Equally, then genitourinary infections, abdominal infections, the skin we discussed about are all pretty common. I won't go much into this, but the idea about actually showing this is that when you have a symptom, how do you do an early diagnosis? You have to understand that these are the places where the infection can occur. For example, the diabetic patients are prone for otitis media and all. So your patient suddenly turns up with, some bit of pain around the face. It is an indicator. It is an indicator that there could be an underlying source of sepsis. It could be the ear canal or it could be the dental area. So that is where you have to start actually thinking about. The diagnosis, you can use multimodalities, but first thing is suspicion. And the suspicion should be raised. And equally, another thing is what organisms are you suspecting? For example, in otitis media and all in diabetic patients, the most common organisms are Pseudomonas aeruginosa. Similarly, you can also have mucormycosis. And in lower respiratory tract infections, basically, they tend to have high amount of gram-positive organisms. But equally, there are times when you can have gram-negatives and atypical. And in urinary tract, the majority of the times you have fungal, that is fungal. How do you go back? Yeah. So you have fungal as well as there is a very high possibility of having gram-negative or beta streptococci. Whenever you have a diabetic patient, just one thing that you have to remember is the risk for pyelonephritis is high. How do you diagnose nowadays? If you ask anybody, one would say, I'll take a history and I'll do an ultrasound and I'll do a urine examination. But the studies show pretty well, and internationally, this is not the way that's done. Ultrasound's sensitivity of catching a pyelonephritis, especially in the early stage, is less than 50%. Unless you have very high resolution ultrasound and you have a very good radiologist. The other thing is, remember one basic teaching. If somebody has fever and you have features of UTI or you are having pus cells, there are studies which show that this is good enough to indicate that the infection has actually entered into the upper tracts of the urinary tract. So even if you are having high-grade fever, the first thing, even if the ultrasound shows clear, my suggestion is treat the patient as pyelonephritis, or you do a CT, because there is a very high possibility of bilateral pyelonephritis or emphysematous pyelonephritis in this group of patients. And this has to be diagnosed pretty early, otherwise you are going to lose the kidney. And the important thing is the most common organisms out here are usually the gram-negative bacteria, specifically E. coli, which has to be kept in mind. Abdominal infections, of course, cholecystitis is very common. Therefore, that is one reason if you ask any surgeon, if the patient of diabetes has a gallstone, it has to be removed. You never leave a gallstone in a diabetic patient left, unlike a non-diabetic patient, because the risk is it will get infected and it will be converted into an empyema. So this we have discussed. And of course, the severe form of skin infections can be necrotizing fasciitis, where again you have a huge load of most commonly the gram-positive organisms. Then you can have picture like this. So, and then you can of course have diabetic foot, which again has multiple organisms. A diabetic foot again has mostly positive, and again then you can also have certain gangrene and clostridial organisms. I know. So you must have asked, why did I talk about all these organisms? The point is, how do you make an early diagnosis? So internationally, even to date, irrespective of what you do, the early diagnosis is made by one is clinical features. You have to stick to your very basics. That is, you have to know your clinical features. The clinical features can include not only fevers, but tachycardia, unexplained tachypnea, abnormal temperatures, hypertension, and local signs. There is no excuse for that. You might do n number of tests, but you are not going to achieve anything if you do not follow the basic pathway. As a matter of fact, in 2022, the Norwegian government did a very simple study to see how doctors are doing early diagnosis. And their criteria are very simple. In first 1 hour, did they document the pulse rate? In the first 1 hour, did they take the temperatures? In the first 1 hour, did they demonstrate or did they document the respiratory rates? And then did they go for the tests? If you do not do that, you are not going to actually catch these early signs. Now, investigation side, of course, we all know about the abnormal leukocyte counts and the possibility of developing thrombocytopenia. But what you have to remember is in the early sepsis, a sepsis which is going to actually land up into a severe MODS, initially you will have respiratory alkalosis. There are times my residents will do an ABG, so there is respiratory alkalosis. And people take this respiratory alkalosis as a very indolent or a very inadequate thing, and they miss out on that. That is a sign, because if you look at it, respiratory alkalosis is not so common until unless you have something happening inside the body, and which slowly and slowly converts into metabolic acidosis because of the development of lactates. If you find a patient here with the metabolic acidosis, especially high lactates, you are doomed. You want to catch them here. यहाँ जब मिल गया patient को, आप यहाँ पे अब you will be running around for how to treat the acidosis. Do I put the patient on dialysis? Do I take him on vent? They have lost your golden hour. The golden hour was here. Equally, you can use CRPs. There are n number of places where you won't be able to catch the organism. So the CRP is an indicator. The CRP indicates that there is something going wrong. And if you do it serially, you get a lot of important information. Think of a CRP which was 50 before, and suddenly the next day or in 48 hours it jumps to 100. That is a very, very indirect way of saying that there is an ongoing sepsis which is going out of control. Other way around, if you have a patient who has a sepsis of 100, you do not have any cultures, you simply give an antibiotic and repeat your CRP, and the CRP starts coming down. Even by 50, starts coming down to 50%, you are sure that whatever you're doing, the antibiotics are correct. So these are the small steps, but there is no alternative to that. Similarly, you can have procalcitonin. Nowadays, procalcitonin is like a, something. Whenever I ask my resident what is happening, sir, uska procalcitonin to 1 tha, uska procalcitonin 50 tha. Do you know how you read procalcitonins? That is something very important. First of all, you never take procalcitonins as single value. The values have to be taken in serial. I mean, even if the most of the studies show that you have to repeat it after 24 hours and see what is happening to procalcitonin. But procalcitonin gives you something in your armory when you are not able to get cultures, and something which comes back fast in most centers nowadays. Even in KGME, you tend to have which comes back within 24 hours. Our cultures will come in 72 hours. The other markers which have come up in recent years are galactomannan and beta-glucan, which is very useful in diabetes because they are fungal markers, and diabetic patients are prone for fungal diseases. Galactomannan, as we know, is an aspergillosis specific fungal marker, whereas beta-glucan is a pan fungal marker, but costs are very high. We'll discuss a little bit about them afterwards. But remember, this does not mean you are not going to take out cultures. You have to take out blood cultures. There is no alternative to that. You want to treat, you want to do a good job, you need to take out cultures. Now, PCT itself, there are certain things you have to remember. The PCT levels are shown to increase 6 to 12 hours following any bacterial infection. So it has a very rapid increase, and it goes on increasing 2 to 4 hours in every 2 to 4 hours. And so if you repeat it after 24 hours, it's going up, then you have a very good chance that this is a sepsis. Similarly, the half-life of the PCT is around 24 hours. So if you want to see if your antibiotic that you have started empirically is doing a good job, you can just repeat it after 24 hours. If they fall in it, then okay, I do not have cultures, but this antibiotic that I've chosen is doing the job for me and I can continue with it. Another important thing is the reports that come as 0.5, 0.52, 2 to 10 in most labs. Of course, nowadays there are some labs which even give something like 50s and 100 PCTs, but that is of no relevance actually. It doesn't make any sense after going about 10. And another important point is most labs will give you the lower limit as 0.25. I keep getting calls, so and specifically from the critical care side, मेरा PCT 1 आ गया, he's in severe sepsis. No, 1 is not severe sepsis. Most data show 0.25 is the lower cutoff, but it is about 2. This red 2 where you should start now thinking about infections. There are n number of causes which will lead to changes in PCT because of other reasons. False positive PCTs, you have to remember, trauma, burns, certain malignancies and immunomodulators used in malignancies. For example, I get these calls every now and then. सर कल GM-CSF लगा था, उसको फीवर आया और आज PCT 10 है, इसको सीवियर सेप्सिस है, इसको मीरोपेनम दे चुके हैं, अब हम इनको देंगे कोलेस्टिन. But actual reason is the GM-CSF is a strong stimulant of PCT. What is it doing? It is stimulating the immune system, and actually PCT is generated when the immune system is activated. Cardiogenic shocks, when there is shock, there is fall in blood pressure, actually the PCT starts coming out. So you should not actually jump the gun the moment you see a raised PCT and a minor rise. 0.1, 2 tak hai, to you should not. Okay, you have a 2 PCT, repeat it next day, it's jumping to 5. Okay, fine. That it most probably this patient is having sepsis. GM-CSF के patients आते हैं, fever का बहुत बार refer होते आते हैं, then we say, okay, fine, the PCT was 10 after GM-CSF injection or GCSF. हम 48 hours में repeat करें, and if it starts falling automatically, that means you are not treating actually sepsis. You're just treating the immune modulation. Another important thing is you should not use PCTs in the first week of the life. It is a very poor marker there. It is a poor marker if you're using peritoneal dialysis. It is a poor marker for cirrhotic patients who are in class C, child poor classification. It can also change with dialysis in CKD patients, and even any line-induced inflammation, like if you have a plasmapheresis going on, it will actually start jumping. And most important, multivitamins itself cause false positive PCTs. अब हमारे यहाँ तो कोई पेशेंट ओपीडी में बिना कोएंजाइम Q10 और B10 के बिना तो आता नहीं है, उनको तो मल्टीविटामिन इज द वन व्हिच गिव्स देम स्ट्रेंथ, बाकी सब तो बगल में है. So you have to remember, don't jump the gun. See what is there on the treatment charts. This is something which specifically I had kept here. PCTs rise in diabetic ketoacidosis. So there are factors even in diabetic patients where you'll have false PCTs. So do not again please keep these things in your mind. False negative. When can you have a negative PCT and still the patient may having sepsis? If you have localized infections, you have a diabetic foot, it's not actually going into the bloodstream directly, you won't have raised PCTs. There is an immunosuppressed condition like you are using steroids. It's expected, its PCT is modulated by immunity, so it will not rise. But most importantly, gram-positive organisms do not lead to the same level of increase. And wherever we saw, for example, otitis media, skin infections, staph aureus, lung infection, do not just rely on your PCT. It is not going to help because those places you are going to have gram-positive organisms. In UTIs, in places where the gram-negative organisms are much more common, there you should actually start relying on PCTs. Otherwise, you will end up with problems. Fungal markers has become pretty common nowadays, and the galactomannan is the most commonly used fungal marker as of now. It is a direct marker of aspergillosis. You also have IgE, aspergillus-specific IgEs, but in ICU settings, the aspergillosis IgE is not used. That is more used in OPD settings. In ICU settings, the galactomannan is a much better marker internationally. That is what is suggested. And BAL galactomannan has a sensitivity and specificity of nearly 90%. But usually we do serum galactomannan. Now, the serum galactomannan has a lot of issues. One issue is that it has false positivities with piperacillin, dasobactams, and amoxicillin. And since your patients in an ICU setting will be on this, a diabetic patient coming with this. So remember, if you're suspecting, do not start them. Or if you have started, then you have to give a washout period of 3 to 5 days and then do your galactomannans. Galactomannans, if high, is a sign that somewhere or down the line you have an aspergillosis infection. The another important thing is labs आजकल देती हैं, but the cutoff they don't understand. Cutoffs is that an elderly patient above 60 will have a different cutoff as compared to a 30-year-old patient. So that is something that you have to keep in mind. It is age dependent and immune dependent. A cancer patient will have a different set of cutoffs as compared to a normal healthy patient. Beta-D-glucan is something which is being recently been introduced even by the ICMR in certain guidelines. And beta-D-glucan, though it came in early 2000s, It is a pan-fungal marker because it's the capsular polysaccharide marker. It's pretty costly. It depends on how many patients you have here. If you are going to send for 1 or 2 patients, then the cost will come around 40 to 80,000. अगर यहीं पर अगर आपके इंस्टीट्यूट में बार-बार अगर भेज रहे हैं, then you will have the cost will drop down to something like 5 to 10,000. But remember that again, it has this false positivities with the antibiotics, not useful for mucor. It has very good negative predictive value. If it is negative, you are sure you're not having a fungal infection. But it also has false positivity with Pseudomonas and Staph pneumoniae. So do not use it where you are suspecting, head and neck infections. वहां पे आप please इनको ना use करें. So I'll conclude here and not go further. Early markers of sepsis anywhere, whether diabetes or not, it depends on 2 things. That is, first and foremost, have a good clinical history and examination. There is no alternative to that, irrespective of whatever you might say. If you are using the molecules, understand their cutoffs and use them serially. Do not take one isolated cutoff and start thinking that the patient is in sepsis. And please do send blood cultures always before starting your antibiotics, irrespective of however much you might think it is necessary to give the antibiotic. Thank you. I think, thank you.
Thank you so much, sir, for such an insightful presentation. We are truly fortunate to have the privilege of hearing your words today. Now we'll go to the felicitation program, and we would like to felicitate the speaker to our chairpersons, and we'd like to request chairpersons to come on stage to felicitate our speaker. Now to felicitate our chairpersons, I would like to request Dr. Anirudh Mukherjee sir to come on stage and felicitate. Dr. Mrithyunjay sir, Associate Professor, Department of Pediatrics. Dr. Amit Mishra sir, Assistant Professor, Department of Urology. And Dr. Pawan Kumar Biswakarma sir, Associate Professor, Department of Medicine, Government Medical College, Azamgarh.
Thank you so much, sir. The talk was indeed a mesmerizing blend of wisdom and expertise that has left an indelible mark in everyone's heart who has been attentive in this session. So for the next session, I would like to welcome on the stage Dr. Gaurav Upadhyay sir, Associate Professor Orthopedics, Dr. Deepak Bhagchandani sir, Assistant Professor Medicine KGMU, Dr. Banasri Nath, Dr. Banasri Nath, from here only, and Dr. Singhal, Assistant Professor, Department of Ophthalmology, MC Library. Let's welcome on the stage Dr. Smriti Singh, our next speaker. She is a seasoned doctor and possesses a unique blend of medical expertise and oratory finesse. We are eagerly looking forward to hear you live on the stage, ma'am. Let's give a big round of applause for her. The topic will be perioperative management of diabetes mellitus.
Thank you, organizing committee, for inviting me here. And it's my privilege that I'm here to deliver a lecture. So today's topic is perioperative management. As you know, perioperative management required a teamwork. Together we can. So there is a teamwork. And whenever there is a teamwork, there is a lots of conflicts there. कोई किसी की बात नहीं सुनता है, कोई किसी को understood नहीं करता है. So that this topic is very important. And for that reason, we require a continuing education activity. Education activity, why we require? To know the pathophysiology, pathophysiology of the stress hyperglycemia, role of various antidiabetic, the optimal glycemic target, and the importance of the interprofessional team approach in providing enhance to the patient during the perioperative period. So here is the together we can. Team means together, only together we can. And what were the objective of these education policies should be the explain the role of history taking. As Dr. Himanshu previously said, the history and examination is a very important key role for the diabetic patient. Because we know as the prevalence of the diabetes is increasing, so that the number of patients going for the surgery per year is also increasing. Describe the insulin management in non-critically and in critically surgical patients. Identify and describe the significance of the optimal glycemic control. Review the importance of improving the care coordination among the interprofessional team to enhance the delivery for care with the diabetes mellitus in perioperative period, including the formation of the discharge plan. Chandrayaan land हो गया, अब प्रज्ञा रोवर को भी वहां पे चीजें कलेक्ट करनी है, so that the discharge is also very important. क्योंकि because patient previously on some medication, operative period में कुछ changes आए and कुछ दिन वो hospital stay किया and then we discharge. So that which medication we have to discharge, all these things are very much required. That is the reason the perioperative management is the whole soul is the teamwork. Hyperglycemia, as we know, the hyperglycemia in perioperative period is an independent marker of a good surgical outcome. Delay wound healing, everybody knows about that. Increased rate of infection, patient land up very well land up in a sepsis and septic shock. Prolonged hospital stay. मरीज तो कहता है डॉक्टर साहब आपने तो बोला था 2 दिन में हम डिस्चार्ज हो जाएंगे या 4 दिन हमारा डिस्चार्ज होगा, हमें तो इतना टाइम लग गया. You have to explain them कि diabetes है, so that the hyperglycemia is very important. And the last one is the higher prosperity of the mortality. That is the worsen thing. The prevalence of hyperglycemia is 20 to 40% in general surgery and 80 to 90% in the cardiac surgery population. Now, this is the some pathophysiology of the hyperglycemia during the surgery. If there is a stress of the surgery, anesthesia and illness, that increase the corticoregulator hormones, that is the cortisol, glucagon, growth hormones, catecholamine. Sorry. That result is decreased insulin, increased secretion, increased insulin resistance, decreased peripheral utilization of the glucose, increased lipolysis and proteolysis that result in increased gluconeogenesis and glucogenolysis. And the overall effect of that, there is a worsen of the hyperglycemia that landed into a stress hyperglycemia. What happens if there is uncontrolled hyperglycemia? There may be a osmotic diuresis that lead into a fluid and electrolyte imbalance. Ketogenesis, increased generation of the pro-inflammatory cytokines result in mitochondrial injury, endothelial dysfunction, and immune deregulation that all cause the worsen of the surgical outcome. Now, the severity of the hyperglycemia depend upon the type of anesthesia and the surgery. If patient, there is lots of studies are there that shows that the increased glucose elevation is mostly more in a general anesthesia in comparison to the epidural or local anesthesia. Same here apply to the surgery. there is lots of research has found that there is an increased glucose elevation seen in thoracic and abdominal surgery in comparison to peripheral and laparoscopic surgery. Now come to the perioperative period management. It's divided into 3 parts: perioperative, intraoperative, and postoperative. Operation se pehle, during surgery, and after the surgery. These 3 parts is very important. Now come to the preoperative period, जिसमें आप कह सकते हो कि एनेस्थेटिस्ट इन्वॉल्व होते हैं, फिजिशियंस इन्वॉल्व होते हैं, and that come to the then the history came is the with the history of the diabetes mellitus. मैं अपने रेजिडेंट से भी कहती हूँ, स्टूडेंट से भी कहती हूँ, आई डोंट नो आजकल का लेटेस्ट ट्रेंड हो गया, एवरीबडी इज इन हरी, डू नॉट वांट टू टेक अ प्रॉपर हिस्ट्री. थोड़ा सा टाइम दीजिए, थोड़ा सा मरीज से टाइम दीजिए, एंड देन यू मरीज को कि वो बहुत सारी चीजें छुपा के रहता है, आई डोंट नो क्यों. अभी प्रीवियस लेक्चर में जैसे सर ने बताया कि वो बहुत स्मार्ट होता है, अगर उसको सर्जरी करानी होती तो 2 दिन पहले फास्टिंग डाइट कंट्रोल करके आएगा एंड आपकी फास्टिंग एकदम नॉर्मल रहेगी. बट HbA1c वाज ऑन हायर साइड. So that history is very important. First, you have to find out if this patient is suffering from a type 1 diabetes or type 2 diabetes. Is there any complication like nephropathy, neuropathy, or retinopathy? Most of the time, they don't tell about the neuropathy symptoms. And then, is patient is on diet control or oral hyperglycemic drug or insulin? Is his blood sugar level is normal? Or she had ever feel the symptom of the hypoglycemia. Its hypoglycemic symptom is also very important. Now come to the surgery. I told you surgery should know, is it ambulatory surgery, elective surgery, emergency surgery, what type of surgery we are doing, is short duration or long duration, because our management depend upon these things. Now come to the glycosylated hemoglobin, that is HbA1c. It is recommended to obtain a perioperative HbA1c to assess the glycemic control and recognize patient with the undiagnosed. If HbA1c on lower side, if HbA1c on higher side, more than 10, it is recommended, if you are going to do a elective surgery, postpone it. Yes, if it is emergency, you can't postpone. And HbA1c is also the marker of that a patient is hyperglycemic within 3 or 6 months, his hyperglycemia is controlled or not controlled. But it doesn't apply to the emergency surgery, because in emergency surgery you have to do it. Some oral anti-hyperglycemic and non-insulin injectables should know that the metformin causes the lactic acidosis in a case of renal dysfunction or with the use of contrast. Sulfonylurea, there is a risk of the hypoglycemia. SGLT2 inhibitors, there is a risk of the euglycemic ketoacidosis in a fasting or acutely ill patient. The fasting, the overlap, patient रात में लिया, उसके बीच में उसने कुछ नहीं लिया, that is the euglycemic ketoacidosis is common in SGLT2 inhibitors patient. GLP-1 agonist worsen nausea and vomiting by delaying the gastric empty. These drugs should be stopped at the day of the surgery. Except the SGLT2 inhibitor should be held 24 hours before the surgery. Again, I am saying these all things apply to only to the elective surgery. Now, before going to insulin therapy, we should know some few things like a basal insulin. Everybody knows about the basal insulin. It is a controlled hyperglycemia when patient is not eating and can be given as a long-acting insulin. Second is a nutritional insulin. We can say it's a parenteral insulin. जब मरीज patient कुछ intake करता है, then only we can give this. That is the parenteral insulin. It's related to a carbohydrate intake, like it may be a meal, internal or parenteral nutrition, either rapid or regular insulin. And then come to the correctional insulin. After giving, you find out that the sugar level is not at that ratio, then we have to give us some additional insulin, that we called it a correctional insulin. जैसे पहले sliding scale होती थी, but now we are not using the sliding scale. We are giving an additional correctional insulin. with the with basal insulin and the parenteral insulin. This correctional insulin should be the same as we are giving a parenteral insulin. If you are giving a nutritional insulin like 4 unit of regular insulin, then we have to, if you want to add on the correctional insulin, we should add the 2 unit of the regular insulin. It's depend upon the whatever the patient was taking insulin. Now come to the insulin therapy. Suppose patient was on insulin therapy. Reduce the dose of long-acting basal glargine or determined by the 20 to 25% the evening before the surgery. But if patient was on high dose of insulin, of basal insulin more than the 60% of the total dose insulin, or total daily dose insulin requirement is more than 80 unit, or at high risk of the hypoglycemic, like the patient is on elderly, renal or hepatic insufficiency, prior hypoglycemic episode, basal dose insulin should be given reduced to the 50 to 75%. Suppose if patient is taking a basal insulin twice daily, then at the day of the surgery, morning, it should be reduced by the 20 to 25% as the day before the surgery. If patient is taking previously twice a day of basal insulin. If patient is on ultra long acting insulin, dose reduction should be made 3 days before the surgery. And if patient is on NPH, that is intermittent insulin, usual dose in the evening prior to the surgery and reduced by the 50% in the morning of the surgery. Patient are still on premix. Most of the patients are still in the premix insulin. That is the combination of the 70 to 30 or aspartame 70-25 or 50-50-50. There is a 3 thoughts of there that preferably patient should preferably receive the basal insulin before the surgery, prior to the surgery in the evening. Stop the premix insulin and give a basal insulin. But most of the time it's not possible. We can reduce the premix insulin by the 50% on the morning of the surgery, followed by the initiation of dextrose containing intravenous solution. Or the third one, skip the morning dose, come to the perioperative region area where the basal insulin should be given. During the fasting stage, nutritional insulin should be held. I told you about the nutritional insulin. It should be regular insulin or ultra short insulin. Patient is not taking. Don't give a nutritional insulin. That is a regular or short acting. That's a basal bolus. Bolus insulin. We should not give that bolus insulin. But we can give a subcutaneous correctional instead with the blood glucose monitoring every 4 to 6 hours. I think now I am clear what is the meaning of the correctional insulin. This is some chart. Same year that I have told you that the long-acting insulin, 70 to 80% of usual dose prior before the surgery, and 70 to 80% of the usual dose if patient is taking a twice daily basal insulin. Intermittent acting insulin prior to surgery, same dose, but 50% of the usual dose at the in the morning at the day of surgery. If patient is on premix insulin, usual dose, and 50% of usual dose given at the morning of the surgery, and nutritional insulin in the evening we can give because patient was NPO after the 9 p.m. or 10 p.m. At that time we can give, but it should be whole in the morning of the surgery. And this is the lower side the table shows the correctional insulin scale. Like this, if suppose blood glucose came around the 150 to 199, and then the standard insulin scale is a 2. If it is 200 to 249, but every 50 we have to increase, add on to 2 more. If it is 200 to 249, we should give a 4, 250 to 299, 6, 300 to 349, 8, 350 to 399, 10. But if there is more than 400, we should take a patient into continuous infusion insulin. But if patient is insulin sensitive, that means if total daily dose requirement is less than 40 unit, or patient is more than 70 of year age, renal or hepatic disease, then we should take a 1 unit lesser than the standard insulin. But if patient is insulin resistant, like is BMI is more than 35 kilogram per meter square, or a high dose on steroid, and total daily dose requirement is more than 80 unit, then we have to add 2 plus 1. We should 1. If it is 2, we should have 3, 4. We should have 3, 6 plus 3, 8 plus 4 and 10 plus 5. I think it's clear. But this dose is different for the night time. If in night at bedtime and 3 a.m. if it is came to the under 200, we should not give her any correctional insulin. But if it is 200 to 249, we should give her 250 to 299, we should add on the 3 unit insulin, and the 300 to 349, it should be that the 4, and 350 to 319 should be the add 5. This protocol should be fixed by the institute for them. हर इंस्टीट्यूट ने अपना एक प्रोटोकॉल बनाया हुआ. It is like some standard protocol, not, but every protocol should be set by the institute only. Critically ill patient, continuous intravenous infusion using a regular insulin is a preferred regime because patient was not taking anything. The use of continuous insulin infusion should be governed by the validated institutional protocol that include a standardized approach for the infusion preparation, initiation, titration, and monitoring. That's the reason I told it's required a teamwork. Because doctor तो वहाँ पे every time monitor करेगा नहीं. Your staff should be know. स्टाफ को पता होना चाहिए हमें क्या प्रोटोकॉल फॉलो करना है, आपको कहाँ किसको इन्फॉर्म करना है. रेजिडेंट शुड बी नो कि हमें कहाँ पे क्या एक्ट करना है. Surgery, diabetic patient, if the patient you are doing a elective surgery, it is advisable the surgery should be scheduled early in the morning and recommended to check the blood glucose in the perioperative region. Whatever the clearance given by the anesthetist or physician, patient can be taken for the surgery, should take RBS before going to the surgery. If blood glucose is less than 70 milligram per deciliter, start giving the dextrose. If patient is blood glucose level is more than 250 milligram per deciliter or metabolic decompensation or HHS, it is prudent to postpone the surgery for the couple of hours for better glycemic control. Blood glucose over 180 milligram per deciliter. Now come to the intraoperative region. हमने perioperative region की तैयारी कर ली, हमें पता चल गया अब हमें क्या करना है. Now come to the intraoperative. Surgery start हो गई. Then we should know to what should we do. If there is a short surgery or is this long surgery. Short surgery if it is less than 4 hours or long surgery if it is more than 4 hours. So if blood glucose over 180 milligram per deciliter or short surgery with expected hemodynamic stability, minimum fluid shift can be managed with the 2-hourly subcutaneous correction insulin, preferably a rapid acting insulin and blood glucose check. Every 2 hours, we have to monitor the blood glucose level and give the insulin accordingly, like I previously tell you about the correctional insulin. If surgery is more than, it's take last longer, more than 4 hours duration, blood glucose level is more than 180 milligram, and it's involved with hemodynamic fluctuation, then should be managed with the intravenous insulin infusion and the blood glucose monitoring every 1 to 2 hours. And we can give a correctional insulin accordingly then. Now come to the post-operative period. Surgery ho gayi. If it take a 4 hour, 8 hour, 10 hour, whatever, patient is shifted to the post-operative unit. If patient is ambulatory and after recovering in the PSU, patient who are stable and tolerating oral intake well can be discharged on the previous anti-hyperglycemic regime. But the only one thing, if he or she is tolerating well the oral intake. Now come to the if patient is non-critically ill patient. Critically ill patient divided into 2 parts. Non-critically management basically there is a slight difference between the non-critically ill patient and critically ill patient. We divided into 2 parts. If patient is non-critically ill patient, but he or she is taking a regular oral intake, then the basal insulin, nutritional, that is a bolus, and if there is in between, we can correct with the correctional insulin. Okay. Now, the poor or no oral intake, patient is taking nothing, then only we should exclude the nutritional, that is a bolus insulin. we should give a basal plus correctional insulin. Now, what happened after that कि हमें कितना देना है, we should divide, the insulin regime can be based on the weight or pre-hospitalized regime. Patient on home insulin with good glycemic control should have their basal insulin reduced by 20 to 25% if the oral intake is inadequate. If oral intake is adequate, then we can take any previously as we have taken. For weight-based dosing, the starting total daily dose of insulin infusion is 0.4 to 0.5 unit per kg per day. Insulin sensitivity should be reduced to a 0.2 to 0.3 unit per kg per day. Insulin sensitive patient, we can start with the 0.6 to 0.7 unit per kg per day. Half of the total daily dose should be given as a basal. Suppose a patient is taking a 60, we found that this patient is on 60 unit of insulin, half of the dose, that is 30 units, should be given as the basal, and 1/6 of the total daily dose is administered as a nutritional increase. Then it should be like 10, 10, 10. When eating blood glucose monitoring 4 times a day and correctional insulin administered accordingly. The patient who is taking nothing by the mouth have blood glucose monitoring every 6 hours for correction with the regular insulin or every 4 hours for rapid correction of the insulin. For a critical ill patient, we should give a short-acting insulin, and there should be the overlap should be proper overlap should be there. If we are not overlapping, then the patient is land up into a hyperglycemic state. Now, the subcutaneous insulin for the critically ill patient depend upon the rate of insulin infusion, weight, and home insulin. When the using of the rate of infusion, the average rate of infusion over the 6 to 8 hours get exploded to a 24 hours. If patient is on minimum or no calorie intake, should be given a 100% of the calculated total daily dose administered as a basal. In patient with the optimal calorie intake, 50% is given as a basal and 50% given as a insulin. For the weight-based total dose is calculated similarly as a non-critical ill patient. There is a multiple randomized control trial shows that the remarkable higher incidence of severe hypoglycemia and increased mortality in a patient subjected to intensive glucose control. So every society have a different range. 180 milligram per deciliter is less than is recommended. The ADA recommended the target glucose rate of 80 to 180 milligram per deciliter in the preoperative period, and 140 to 180 milligram per deciliter the majority of the critically ill and non-critical ill patient. Sir, time kuch left ho gaya, so should I finish it?
2 minutes, ma'am.
2 minutes, so I will finish within 2 minutes. Now, some of the special circumstances like a type 1 diabetes mellitus, due to a minimal to no pancreatic beta cell function, type 1 diabetes should have a basal supply of insulin at all time. Even if patient is not taking anything from the mouth, either subcutaneously or intravenously, failure to do so we can cause the decompensation to diabetic ketoacidosis. If patient is on insulin infusion, it is recommended to restrict to the procedure of a few continuous insulin pump inappropriately should be restricted to a procedure of fewer than a 2 hour of duration. And a patient knows an insulin infusion, हमें जितनी requirement है, we can give from that pump. Now, the eternal nutrition should be preferably receive formula containing low carbohydrate, high monosaturated and fatty acid. It is commonly used in a traumatic patient or in surgery. Usually, 30 to 50% of total daily dose is administered as a basal insulin once or twice daily. The remaining 50 to 70% of total daily dose is added as a nutritional insulin. Dose of nutritional insulin is 1 unit of rapid acting or regular insulin for every 10 to 15 gram of carbohydrate. And we have to monitor the every 4 hours, and depend upon we can give a continuous correctional insulin. Now, if patient is on parenteral nutrition, patient is either as a separate intervention or add on to the total parental nutrition. Suppose patient is on RT feeding, we should give a insulin prior to the RT. We should divide the or RT feed the 4 to 6 hourly. We are giving a 6 meal or 8 meal, and then we can give a insulin accordingly. Then we divide that this much is the basal insulin, and other ones are that is the our nutritional insulin. We can give. Suppose patient is on a pre-breakfast, pre-lunch, pre-dinner, there is 10 unit, we can give a 10 unit. Same if patient is not RT feeding, we can give a bolus insulin in first feed, then after third feed and the fifth feed. You can divide this, but don't give a patient as RT feeding. We will give either continuous infusion. That is not a good thing. We have to give a subcutaneous insulin with the nutritional or we can add on with the correctional insulin. If we have patient on TPN, 1 unit of regular insulin for every 10 gram of dextrose and the regime adjusted every 1 to 2 days based on the glycemic trend. Start a separate intravenous infusion insulin once the blood glucose within the glycemic goal. 80 to 100% of the total insulin dose provided जो हमारे previous जितना हमने calculate किया है, we can add it by infusion to the TPN solution. And same thing is there, every 4 to 6 hours we have to monitor hypoglycemia. It's very important. Heterogenic hyperglycemia is very common और जब हो जाता है तो we can जैसे अभी starting के lectures में बताया कि बच्चा नहीं खाता है तो फिर उसको hypoglycemia मदर ने feed कर दिया, फिर हमारा sugar level high हो गया, फिर patient को hypoglycemia हो गया, फिर आपने sugar level high हो गया, आपने higher insulin दे दिया. It should be not there. That is a heterogenic hypoglycemia. It occurred because of the inappropriate dose insulin, aggressive glycemic target, insulin administered not aligned with the meal time. It's very important. Insulin is taking unfrozen changes in a caloric intake, poor provider and provider nurse communication, failure to recognize glycemic trend or intervene are a few factors that risk of hypoglycemia in a perioperative region. Now, the last one thing that I started my lecture, the teamwork is important. If there is a team, proper communication, what we have to do, what to not to do, then every diabetic patient come with a better surgical outcome. So together we can. Thank you. Any question from audience side?
Madam, I have one question. I'm an orthopedician with that relevance. I would like to ask you what is the consensus of guidelines regarding the level of preoperative HbA1c before any elective surgery? Some guidelines say 10, some say 9, some
there
say
is a lot of controversies about that. Some people thought that the HbA1c is the marker, is the poor marker for the
prognosis
of the surgery, and some said that this poor uncontrolled HbA1c is the poor marker for the hyperglycemia. That causes the hyperglycemia. That's the reason patient landed to the
infection
surgery. Most of the time you find that the HbA1c was on a higher side, but patient fasting and PP was not that much higher. Most of the time patient came with the HbA1c was the 10 and his fasting was 110 and PP was not normal. We can't prescribe any medication because we are giving a medication on the basis of the fasting and PPBS, not on the basis of the HbA1c. HbA1c is the marker, and lots of other things are there that affect the HbA1c. Like it is HbA1c, it is a hemoglobin. Lots of things are there. It is not accurate that way. But yes, if HbA1c was on higher side, I already told you, if it is elective surgery, it is advisable to postpone it. It is emergency, you can't do anything. But HbA1c, there is lots of controversy, lots of studies are there, but still there is a two school of thought. One is saying it is a poor marker, and one is saying it is denote that the patient is not having a good hyperglycemic control, so that patient landed into a poor surgical outcome.
Okay. Thank you.
Ma'am has clearly explained in details everything, the pre-operative, operative, and the post-operative management. One thing just I want to add
to the residents and tell that, and the start ma'am has told that residents are nowadays in a hurry to just to do surgery. They are not very much concerned for the pre-operative management. It's really important because nowadays the medical legal cases are also going on. And one thing I want to add that in taking into consideration all these pre-operative management, proper documentation of all these things in the file is very important. Whatever you prescribe, you should always document it in the file, because if there is no documentation, any verbal communication has no value in future. So a proper documentation of all the treatments that has been prescribed, mainly if the patient is really hypertensive and uncontrolled diabetes, then in that case, of course, it is mandatory that everything should be documented properly.
It's true, documentation is very important.
Documentation of everything is very important because nowadays residents are missing these things. They are in a hurry to learn the surgery only. They are not very much concerned about the.
Dr. Dayoda sir has also said that the history is very important. If you are taking a history, then definitely you will write something.
As an ophthalmologist, I have also seen that if the proper pre-operative evaluation has been not done, then many times we land up intraoperative complications. So pre-operative management, pre-operative assessment of the patient is very important.
So that my keyword is that is a team.
Yes, it is sure a team effort. Thank you.
Thank you, ma'am, for such an captivating talk. Now I'd like to request our all chairpersons to come on the stage to felicitate our speaker, Dr. Smriti Singh, ma'am. Please give her a big round of applause. Now to felicitate our respected chairpersons, I would like to call upon the stage Dr. Mahendra Meena, sir. I would like to go first with Dr. Gaurav Upadhyay, sir, Associate Professor Orthopedics. Okay. Dr. Deepak Bhagchandani, sir, Assistant Professor Medicine, KGME. Dr. Banasri Nath, Associate Professor Gynecology, AIIMS Raebareli. And finally, Dr. Srinkal, Assistant Professor Ophthalmology, Raebareli. Now, without any delay, we would like to proceed to the next session. And to chair the next session, I would like to welcome on the stage Dr. Sunita Singh, ma'am, Associate Professor, Pediatric Surgery, Dr. Sefali, Assistant Professor, Microbiology, and Dr. Nilesh Kumar, Associate Professor, Medicine, BHU, Banaras. As we move to the next session, we do with great anticipation. I would like to welcome our next speaker to enlighten us with his expertise and wisdom. We call upon the stage Professor Bikram Singh, sir. As we all know how effortlessly he weaves his knowledge, painting the vivid image and insight into our attentive hearts. Let's give him a big round of applause. Sir. And to introduce our speaker, I would like to request Dr. Sunita Singh, ma'am.
Good afternoon, all. I thanks the organizing committee to give me the opportunity to introduce our esteemed speaker, that is Dr. Vikram Singh. He did his MBBS and MD from the IMS BHU, and he is presently working as a professor and head Department of Medicine, RML Institute of Medical Science, and he is also medical superintendent of the RML. His major achievements are that he got the Global Scholar Program of American Diabetic Association in 2014 and did observership in field of rheumatology at Singapore General Hospital. He has more than 14 publications and various intramural projects as he did in the AIIMS Jodhpur. So I welcome Professor Vikram sir. Thank you.
Good afternoon, and everyone. My topic is rheumatological complication of diabetes, which is a relatively neglected areas because we clinician don't treat rheumatological complications. We generally consider them as a part of orthopedic. So the objective of presentation will be what are the various rheumatological diseases, how do we identify them, and how do we treat them. So it can be classified various ways. One is the what are the musculoskeletal structures that they affect and whether they are painful pathologies or non-painful pathologies. We almost every structure of the heart is involved. Like in hands, we can have a carpal tunnel syndrome. We have a Dupin's contracture. We have a trigger finger. In shoulder, very common, it is a frozen shoulder or periarthritis. In lower limbs, we have a Charcot joint. Then we have a muscular infractions because of diabetes. And there is a dish syndrome in the spine. All these diseases can be classified whether they are painful or non-painful. The non-painfuls are, there is a word that is a diabetic chiroarthropathy, that is a limited joint mobility, which is seen generally in the upper limb, the Charcot joints, the trigger finger. These are basically a painless disorders, and muscle infractions, osteoarthritis because of diabetes, and chronic regional pain syndrome. These are painful disorders. One of the most common that we encounter in our clinics is the patients with the frozen shoulder, or that is a adhesive capsulitis. I think there is again some slides are missing. स्लाइड शेयर पे मत करिए, जो स्मॉलर वर्जन है उस पे करें. स्लाइड शेयर पे हाँ. So this frozen shoulder is a progressive, painful and condition, and where there is a, and the patient, how the patient present with the pain in the either single joint or the bilateral shoulder joint, and there is an extensive pain when the patient is doing an external rotation. It's not working. आप next कर दीजिए. So what is the basically pathogenesis? The pathogenesis is because of the hyperglycemia, there is a collagen interlinking takes place, and this collagen interlinking takes place in the capsule, and then the capsule around the joint gets inflamed and fibrosed, and then there is a volume of the capsule is decreased. That's why there is a extensive pains take place. Next. What is the prevalence? It is though it is commonly seen in the general population, but it has a very high prevalence, at least seen in the 20% of the patient of diabetes. Women are more prone than men, and generally it is a more bilateral rather than the unilateral. It has a three phases. The first phase is which lasts for up to 4 to 7 months. Then there is a pain and stiffness in the shoulders, and we found that there is no history of any injury. Next, the next phase is adhesive capsulitis that lasts for 4 months to 12 months. There is a gradual pain disappears, but stiffness continues. Next, and then there comes the resolution phase, which lasts up to 36 months. Generally, the natural history is that the pain of the frozen shoulder decreases by 36 months. As we have already discussed that the patient present with the pain in the shoulder, especially during the nights, the pain gets aggravated during the external rotations. Next. In the general examination of the shoulder, we can find that features of inflammation like the swelling, redness, and warmth. Next. Generally, the plain X-ray is not very helpful in the diagnosis of this condition. However, in the ultrasonography, we can see whether the what is the volume of the periarticular capsule and what is the total stiffness of the capsule. However, we can also rule out the rotator cuff injury and bursitis by the ultrasonography. However, ultrasound is not the diagnosis, the investigation of choice. MRI should be done. Next. In this X-ray, we are seeing that how the capsule is become thick and contracted, and that is generally seen in the patient with the frozen shoulder. Next. Treatment, it is generally it is a self-limited condition, but the self-limitation takes place after 42 months. So when the patient is in acute phase, we have to give non-steroidal anti-inflammatory drugs. A very prolonged physiotherapy has to be done. Intra-articular steroid injections can be given. In the non-responding cases, we have to remove the fibrous capsule. Then the other non-painful condition is a neuropathic osteoarthropathy. The next slide. It is basically a progressive disease, takes place because of neuropathy and recurrent mechanical trauma. And because of the neuropathy and recurrent mechanical trauma, there is a microfractures take place. And because of this microfracture, the charcoid joints take place in the patient with the diabetes. So this was the pathogenesis. Next slide. It is though generally seen in the elderly patients who are having neuropathy, but more common as compared to general population diabetic patients. And as the duration of diabetes increases, the chances of charcot joint increases. Next. So the patient present with the arthritis, that is an inflammation of the joints, as well as there is because it is a very slow process, there is also a destruction of the joint. There are the 4 phases of this destruction. First, there is an inflammation. On the inflammation, we cannot identify with the X-ray. However, during the developmental stage, there is a effusion and subluxation of the joints takes place. Next, then there is a coalescence stage when there is a new bone formation and subchondral sclerosis takes place, and ultimately there is a remodeling stage where the decreased sclerosis and reabsorption take place. So this is the way a full-blown charcot joint is seen. Next slide. Next. The best treatment is that once it is developing and the patient is showing the initial symptoms, weight should be restricted. And restriction of the weight bearing should be done for the 3 months. Non-steroidal anti-inflammatory drugs can be given for the decrease the inflammation. Bisphosphonates can be given, and if patient is coming into the late stages, then the surgical debridement of the bones can be done. Next is the carpal tunnel syndrome. Again, not clinicians are not much interested in this. What is this? There is a compression of the median nerves takes place, and because of this compression, the patient present with the tingling sensation and a paresthesia in the thumb, middle finger, index finger, and because it is because of compression, so it is called as a entrapment in neuropathy. It is generally seen in the patients who are having a polyneuropathies. Symptoms have already discussed. Next. It is also associated with the autonomic features. So there is a temperature and color change in the hands takes place. Next. How do we diagnose? For diagnosis, there are two tests. That first is a Fallon test. We ask the patient to keep hands in this way. And if the patient keep in this way his hand, after 30 to 120 seconds, there is a tingling sensation and paresthesia takes place in the median nerve distribution. And there is another test that is a Tinel test. When we tap over the carpal median nerve, there is a paresthesia in the distributing areas. Next slide. So there is a no lab test. It is a clinical diagnosis. However, for the confirmation of clinical diagnosis, nerve conduction velocity and EMG can be done. The EMG and nerve conduction velocity will tell you about the neuropathy. However, whether how much compression is there or not, at what the site, for this we should go for the ultrasonography, which has a sensitivity of 64%, but the ultimate diagnosis can be done by the MRI, which is having a sensitivity of around 90%. Next slide. Treatment. That whenever the patient is having a features of carpal tunnel syndrome, he should be given sprinting for 3 weeks. The steroid injection can be given, or for decreasing inflammation, anti-inflammatory drugs. If the patient is having still pain, then the surgical resection of the compressions to be done. Next slide. The another term which is common not only in the diabetic but also some other persons who are having trauma, that is a reflex symptomatic dystrophy. Next slide. It is also called as a regional pain syndrome type 1. In the regional pain syndrome, the pathogenesis is that there is a neuropathy or there is a damage to the peripheral nerves, because of which the sensation of that area as well as the autonomic features in that localized area took place. And it is a very common when the patient is undergoing a surgical resection or patient is having a diabetic neuropathy. It is generally present with the patient present with a loss of sensation, paresthesia in a localized area, along with the swelling, vasomotor disturbances, and trophic skin changes in that particular area. Next slide. Though pathogenesis is not known, but it is because of the neurogenic inflammations and central nervous system sensitization. The history, as we have already discussed, that the patient present with the pain, paresthesia, as well as vasomotor changes in that localized area. Such type of vasomotor changes in form of swelling, redness, place when the patient present with the regional pain syndrome type 1. In the physical examination, as we have seen, that the skin will be shiny, swollen, the temperature will be raised, and joint will have a stiffness. Next slide. The best treatment is early mobilization of that area. Otherwise, we can only give symptomatic relief by the way of anticonvulsant like the gabapentin, tricyclic antidepressant, or the analgesic. Invasive therapy can also be given by the way of regional pain sympathetic nerve block or electric nerve stimulation. Then and there is another terms very commonly we call it as a trigger finger, that is a flexor tenosynovitis, and it takes place because of the non-infectious inflammation of the flexor tendon sheet of one finger. There is a contraction and stiffness in the flexor tendon, as a result of which the finger become trigger like. So it is called as a trigger finger. Next slide. And why in this? Because the flexors of the fingers are stronger than the extensor muscles. That's why it is called as a trigger finger. Next. It is estimated that 11% of diabetic generally present with a trigger finger in our OPDs. How the patient present? Patient present with a pain, stiffness of the finger. Next slide. How do we know that the patient, if we ask because patient is having this type of finger, if we ask the patient to show a prayer sign, the patient will have this type of fingers. So the prayer sign is a test which we can use in our clinic to know whether the patient is having a trigger finger or not. Next slide. Again, it is a bit because of the stiffness and inflammation of the tendon. So splinting is to be done, and otherwise to decrease the inflammation, non-steroidal inflammatory drugs or steroid injections to be given in these patients. Next slide. A very important, which is not related to the orthopedics component of the rather than medicine, and sometimes the patient of the diabetic present with a swelling in the thighs or in the muscle mass. We generally consider these patients as a case of cellulitis or deep vein thrombosis, but actually these patients are a case of ischemic necrosis of skeletal muscle. And the pathogenesis of ischemic necrosis of the skeletal muscle is because of the poor glycemic control, and poor glycemic control causes the platelet dysfunction and it creates a thrombotic state in the capillaries. So that is the pathophysiology of the ischemic myonecrosis in diabetes, and generally seen in the thigh muscles or in the muscles group where the muscle mass is more. Next slide. So as we have discussed that the differential diagnosis of this myonecrosis is DVT or cellulitis. So the patient present with a tender and the swollen leg, pain is of acute in onset. Sometimes it is associated with the autonomic symptoms, and there will be no history of trauma. Next slide. How to diagnose whether it is a cellulitis or it is a deep vein thrombosis? When we do MRI, in MRI we can identify that there is a necrosis of the muscle is taking place, as well as during the ultrasound we can identify that it is a necrosis of muscle rather than it is a abscess. Next. Next slide. The gold standard is a muscle biopsy, but muscle biopsy should not be done unless it is a atypical presentation, because the patient is already diabetic, and if you are doing some incision, then there will be poor healing. However, theoretically, muscle biopsy should be done. The treatment is rest, anti-analgesic, and anti-platelet therapy to these patients. But whenever there is an infection, they are also prone for the infection. So gram-positive antibiotics should also be given in these patients. So these were some of the musculoskeletal disorders that we seen in diabetic patients. Any questions related to it? These are just summaries of the what we have. No. It is basically mild if you will give antiplatelet or antibiotic. Generally, you do not require a fasciotomy.
The severity of
Yeah.
is little.
Because it is not infectious process.
Get relief with their symptoms. Like basically paresthesias keep on persisting. So what is your take? What should we do in preoperative workup or postoperatively? Even with complete resection of carpal tunnel, there are patients who are complaining the same tingling and paresthesias even after that.
Look, because it is because of neuropathy as well as compression. So you are treating one, you are decreasing compression. So neuropathic symptoms will be there. Only you can minimize it. You cannot completely eradicate it.
Other than pregabalin, gabapentin.
No, there is nothing else.
Thank you so much, sir, for such an intricate, crisp, and thought-provoking talk. Now, I would like to request all the chairpersons to felicitate our speaker on the stage. Please give a big round of applause. And now to felicitate our respected chairpersons, I would like to call on the stage Dr. Mukesh Bhairwa, sir. First, I would like to call the name Dr. Sundar Singh, ma'am, Associate Professor, Department of Pediatric Surgery. Dr. Sefali, Assistant Professor, Microbiology. And finally, Dr. Nilesh Kumar, sir, Associate Professor, Medicine, BHU Banarasi. Now, as we move to the next session, I would like to call on the virtual stage the lady who is just not an authoritative leader, but also an accomplished director and possesses an aura of commanding confidence. With great honor, I call up on the virtual stage Professor Dr. Surekha Kishore ma'am, Executive Director, AIIMS Gorakhpur and Patron of Cardio-Diabetic Society. It was a privilege to work with you in the CDS conference last year, ma'am. Let's welcome her with a big round of applause. And for chairing the session, I would like to call on the stage Professor Dr. Ravikant, sir, Professor and Head, Department of Internal Medicine, AIIMS Rishikesh, Dr. Arijit Jordar, sir, Assistant Professor, ENT, AIIMS Raebareli, and Dr. Mukesh Shukla, sir, Associate Professor, CFM, AIIMS Rishikesh, AIIMS Raebareli. And I would like to request Ravikant, sir, to introduce the speaker.
Yeah, it's a proud privilege to introduce one of the authorities in the field of preventive cardiodiabetes. And in fact, I'm honored to introduce Professor Surekha Kishore, Executive Director, AIIMS Gorakhpur, for delivering the lecture. And she has so many accomplishments and she has done so many projects, both in field ICMR government projects, pilot studies, and the noble data that she has given to this country for framing the strategies to tackle the non-communicable diseases in India, especially rural settings. Madam is having 20 years of experience teaching, training, research related to medical, paramedical students and non-teaching staff. She has research work includes more than 115 projects, international, national, and I am fortunate to have part of some of her projects which are sponsored by or funded by ICMR and some other international societies. She is recipient of CDEFCON Award by Southeast Asian Diabetes Foundation chaired more than 130 sessions in conferences, workshops, and seminars, reviewers of various national and international journals. She is a life member of various national and international associations, and there are so many more, journals to which she is editor-in-chief or executive editor. I call upon and invite Madam Professor Rekha Kishore for delivering her lecture, and she will be talking about managing, cardiodiabetes by lifestyle modification. So, welcome, Madam, for on the time. Thank you.
Thank you, Dr. Ravikant, for your kind words. At the outset, I would like to thank all the chairpersons and the organizing committee for giving me this opportunity for presenting this topic on pre-diabetes and its management through the lifestyle modifications. So I would like to share my presentation, and should I begin with the presentation, I would seek the permission of the chairpersons, please. Is it okay? Should I begin with?
Yeah, please go ahead, ma'am.
Right, please. Share the presentation, please. Yeah, please change. Next. Now, let me just define. I think all of us are aware of what is pre-diabetes, as all of you are experts in this field. So just a quick recap that as per WHO definition, the impaired fasting glucose when it is beyond 125, that is the normal is 110 to 125. If it is beyond that, then we would call pre-diabetes as 110 to 125. Impaired glucose tolerance test, which is 2 hours plasma glucose of 140 to 200 milligram per deciliter after introduction of 75 grams of oral glucose load. And as per American Diabetes Association, where HbA1c is 5.7% to 6.4%, impaired fasting glucose level between 100 to 125 deciliter, and it uses a lower cutoff value. And impaired glucose tolerance, 2 hours plasma glucose of 140 to 200 per deciliter after 75 milligram of oral glucose load. Next one, please. So all of us are aware that pre-diabetes accounts for the raised blood sugar level, and it is beyond the normal one, but not high enough to be classified as diabetes. Then when you have pre-diabetes, pre-diabetes is also referred to as an impaired fasting glucose or impaired glucose tolerance. It is used to be called as borderline diabetes. And we all are aware of that 1 in 3 of individuals are suffering from pre-diabetes, and the worst part is that they don't even know that they are suffering from pre-diabetes. And we also know the impact and consequences of long-term pre-diabetes leading to stroke or multi-organ failures and effects. Next one. This is again one of the slide taken from CDC, which indicates that again 1 in 3 adults have pre-diabetes, and various risk factors which are associated with pre-diabetes, including people who are beyond 45 years, and this is more so in cases of males, and people who are overweight, women who have had gestational diabetes, and parents or siblings, those people whose parents or siblings they had diabetes or they are suffering from diabetes, people with high blood sugar, high blood pressure, sorry, and those people who are living sedentary lifestyle. Next one. People who are suffering from pre-diabetes when they move towards diabetes. So this is just the 3 tests which would indicate that people who are pre-diabetic, their cutoff levels as far as the HbA1c test is concerned, the fasting blood sugar test, and glucose tolerance test is concerned. This again I have already mentioned earlier. Next one. Now, this is the estimated prevalence in age group of 20 to 79 years, wherein it has been shown that in Europe, diabetes mellitus the increase from 2003 to 2025 is approximately 20% rise, and impaired glucose tolerance was in increase as 10%. Whereas in Southeast Asian countries, if you see, diabetes mellitus has shown a jump to 110% from 2003 to 2025, and IGT 60% rise. So this is something which is of concern and importance for all of us who belong to Southeast Asian region. Next one. Now, all of us are aware of this ominous octet of diabetes mellitus and all the 8 important factors which are leading to hyperglycemia in the cases of pre-diabetes and diabetes. Next one. Now, the pre-diabetes and how to prevent it from becoming type 2 diabetes with various lifestyle changes. Before I go into the details, since we are into the era of evidence-based medicine, so some evidences which have been generated by various studies, I'll just put forth why are we bothered about lifestyle changes and which are the lifestyle modifications which are required to prevent pre-diabetic going to the journey of type 2 diabetes. So how to prevent it? So what are the various factors and the lifestyle modifications? So there are various studies which have covered these factors and shown that if we follow these lifestyle changes in our life and we do these modifications, then definitely we can prevent type 2 diabetes or further complications, and it will also lead to reduced sugar level. Along with that, there are other important factors which will be revolving around it. So I am just going to present those studies. Yes, next one, please. Now, feasibility of preventing type 2 diabetes, let me just mention here that there is a long period of glucose intolerance which precedes the development of diabetes, and screening tests can identify those persons who are at risk, and there are safe, potentially effective interventions which will address the modifiable risk factors, which all of us know that in all the non-communicable diseases, these are the important modifiable risk factors: obesity, the fat distribution, the basic physical inactivity, and high blood glucose level. Next one. Now, how do we reduce the risk and prevent the type 2 diabetes? Basically by controlling the cholesterol level, the blood pressure levels, and improving our sedentary lifestyle to going for exercises and non-sedentary lifestyles, and then reducing the weight, and definitely, yes, reducing the fat content as well. Next one. The goals of pre-diabetes management include prevention of delaying the onset of diabetes, number one. Second is preserving the beta cell function. Third is prevention and delaying the microvascular and cardiovascular complications. And then ultimately reducing the cost of diabetes care on the patients. Next one. Various interventions to reduce the risk which are associated with pre-diabetes is therapeutic lifestyle management is the cornerstone of all prevention, and no pharmacological agents are currently approved for management of pre-diabetes, and pharmacotherapy targeted at glucose may be considered in high-risk patients only after individual risk-benefit analysis. These are the important points before we go for therapeutic interventions as well in cases of pre-diabetes. And then I'm now going to show you some of the studies which have been conducted and their findings. Please, next one. Now, the important selected lifestyle modification trials which had been undertaken. The first one is the DPP program, that is Diabetes Prevention Program, which was conducted in USA, which was a long-term follow-up randomized control trial in which more than 3,000 people were taken into consideration. And as we can see, where after the intervention of around 2.8 years, they found that the relative risk reduction of diabetes and sugar levels was markedly seen and found in 58%. There was 58% reduction in intervention group as compared to the non-intervention or control part. And secondly, in diabetes prevention study, this was again one of the program which was took place in Finland. And here also you can see that the relative risk reduction percentage was 39% in the intervention group, and Darking study, which was held in China, wherein the risk reduction was found to be 51%. So all of these three studies, they have shown that there was definitely a risk reduction in cases of those people who were at risk by changing their lifestyle. After modification and interventions, these risk reductions were seen. Now a little bit of details and some graphics. Please, next one. Now, this was the DPP program, and this was the diabetes prevention program outcome study, and it was a long-term, like I said, long-term follow-up and randomized clinical trial to prevent type 2 diabetes in persons at high risk. So all the people who were at high risk, they were made eligible for this study. Next one, please. Now here you can see that when the exercises plus diet, there was one group where exercise and diet was introduced. Another group, metformin was given, and there was one more group where placebo was given. So here it was found that there was a reduction in the incidence of the type of diabetes to 58%, which is remarkable. Next one, please. Now, here you can see the intensive lifestyle intervention effectively prevents progression from impaired glucose tolerance to type 2 diabetes development. So here again, you will see that the diabetes incidence per 100% years was, 4.8% in intensive lifestyle interventions, and 58% reduction was found. And in cases of metformin, it was 31%. Whereas in cases of placebo, you will find the number of cases of diabetes is quite high as compared to the lifestyle intervention. There you will see that the number of cases were comparatively on the lower side. The diabetes in patients was very low. Yeah. Next one. The lifestyle interventions more effectively prevents diabetes as population age. This was again another finding in this DPP study, where it was seen that 71% reduction was seen in cases of diabetes incidence per 100% years, and this reduction was more in the age group above 60 years. And this you can see that the green bar is for those people who were in the intervention group. So as far as placebo was concerned, there was no difference in the age group, but in the intervention group you will see that the changes were marked when the age group was beyond 60. So that means that lifestyle modification and interventions definitely helps the old age people as well. Next one. The effectiveness of lifestyle intervention for diabetes prevention wanes as the weight increases. Yes, we also know that overweight is again one of the causation for diabetes and hyperglycemia. So here you can find that as the BMI increased, and you can see that the diabetes incidence was also 51% per 100%. So here you will find that incidence was more when the BMI was more. So BMI is directly related to the increase in the incidence of diabetes in people or pre-diabetes as well. Please, next one. Now, when we saw the incidence of diabetes overall, and this graph shows the cumulative incidence. Here you can see that the incidence of diabetes was comparatively lowest when in the group of people who were in the lifestyle modification group, and people, second was in the metformin group, and the last one was in the placebo group. So this means that incidence, though incidence, you can see it was rising, but at the same time, it was far more lower in cases of people in the intervention group where lifestyle modifications were done. Next one. Now here you can see that maintenance of long-term weight loss, because this weight loss, long-term weight loss was also one of the factor which was undertaken in this DPP program, the weight control and weight management. So they saw that the long-term management, if you see in the placebo group, the weight was almost in the same line, whereas in cases of people who were following the metformin medication or who were in the lifestyle interventions, their weight was maintained, and it got lowered as well as maintained for a longer period. So long-term weight loss definitely has got an impact on the reduced sugar levels and control of diabetes. Next one. Now, again, one of the finding from DPP was that, women with a history of gestational diabetes mellitus, we all of us know that progression to diabetes is more common in women with a history of gestational diabetes mellitus versus those who do not have that. So both intensive lifestyle and metformin are highly effective in delaying or preventing diabetes in women with IGT and a history of gestational diabetes mellitus. Next one. Then this was the second trial in which this was called as Finnish Diabetes Prevention Study, where 522 patients were undertaken between the age group of 40 to 65 years. And IGT was done on 2 occasions, and interventions in the form of reduction in body weight and dietary fat, as well as introduction of dietary fiber, fruits and vegetables, and increasing their activity, physical activity. So these were the interventions which were undertaken, and the usual care for the pre-diabetic patients. Next one, please. Here they found that diet interventions again had a marked reduction in the incidence of diabetes, and as you can see in this graph, that there was 58% reduction, and incidence was 58%, which was seen in the people who were in following the modified diet as compared to the control group, where though no intervention was done. So this study definitely enhances the impact of diet, or we can say the healthy diet. Introduction of healthy diet definitely leads to the reduction in the incidence of diabetes. Next one. This was again another finding in which you can see that incidence of diabetes as per the cases 100% per year, and this was in cases and control and intervention group related to diet and exercises. And here again you will find that the blood sugar level, fasting blood sugar level, as well as postprandial glucose level were at the lower side in cases of those who followed the interventions in terms of diet and exercises. Next one. This is again the depiction of the same slide. I think this again has shown. Please. That fasting and the postprandial glucose levels, the reduction is much more in cases of the intervention group as compared to the control group. Next one. Next. The cumulative incidence of diabetes over 4 years, as far as the Finnish diabetes prevention study goes, we find that again, this also shows that there was 58% reduction in the incidence of diabetes per cases per 1,000 person years. Next one. This was another study, Darking Diabetes Prevention Study, where cumulative incidence of diabetes in Asian patients with impaired glucose tolerance is seen. And here again, if we see that people who were overweight and lean, if we compare in all the groups, you will find that people who were dieting, exercising, and both, there is a market change from the control group. If you compare it, we will find that patients with type 2 diabetes, after these interventions, the incidence is much more less in patients who were following controlled diet, who were doing the exercise, and people who were following both diet as well as exercise. Next one. Now, this is again 23-year incidence of type 2 diabetes in Asian patients with impaired glucose tolerance. Here also we will see that the diabetes proportion of participants, the diabetes is much lower in cases of intervention group as compared to the control group. So blue line is the intervention group. So we will see that these patients are show much more lesser levels as compared to the control group. So definitely somewhere or the other we see that the intervention plays an important role in terms of the diet control, exercises, which was the main important intervention taken up here. Next one. This was another systematic review and meta-analysis, and this was the pooled result of 16 randomized controlled trials, which showed that people with pre-diabetes who received lifestyle intervention had lower rate of progression to type 2 diabetes. And majority of the studies, they have shown that greater weight loss in life intervention participants with a great variation between the studies, and cost per quality adjusted life year was very much lower with the benefits of lifestyle intervention as compared to those people where intervention was not there. So quality of life as well as the cost, both of them were different, and intervention group definitely had a reduced cost for the quality adjusted life year. Next one. So, for managing the diet for pre-diabetes, I think all of us know that the food for pre-diabetic should include lot of fruits and green leafy vegetables along with legumes, nuts and seeds, and whole grains, lean proteins, and reduce intake of sugar and high glycemic foods, avoiding alcohol and smoking, and yes, fiber rich food as well as protein rich food, and lesser of the carbs. Next one. Control of weight or weight management definitely plays an important role that we have already mentioned. I'm not going to go into the detail of how we are going to follow the weight management. Once you control the diet and you undergo your various sets of exercises or simple walking also, and minimum at least half an hour 5 days a week would also suffice. So weight management would definitely improve the blood sugar level and would prevent a person from pre-diabetes going to type 2 diabetes. Next one. Walking and brisk walking and exercises definitely play an important role. I have already mentioned it in the previous slides that and studies have also put up the evidences. Next one. One more important thing which probably have not been studied much is stress and proper sleep. Now, these two are again very important factors leading to probably because nowadays a lot of people are suffering from diabetes, high blood sugar level, maybe because of increased stress. So somewhere stress definitely plays an important role, and we know that we have a hormonal axis and cortisol levels. All there is an interplay of hormones, and somewhere the stress triggering the formation of a person going from pre-diabetic to diabetic, type 2 diabetic. So stress factor has to be controlled, and for that I think good sleep is needed, And of course, if one does yoga and meditation, definitely that would uh, reduce the stress. It will not allay the stress, but definitely it will reduce it. Next one. To summarize, the goals of pre-diabetic treatment are preventing or delaying the onset of diabetes, preserving the beta cell function, and preventing or delaying the complications. So we need to identify the individuals with pre-diabetes. And for that, we definitely need a lot of screening programs, usually which are lacking in India or in developing countries. So screening programs for screening the pre-diabetics should be there, so that we can manage these pre-diabetics with these interventions, which have lifestyle interventions, lifestyle modifications, so that they don't turn up to type 2 diabetes. So early intervention can only be done once we identify them early. So screening of the population, screening of individuals is a must. And then definitely, yes, lifestyle interventions in terms of regular exercising, weight loss, and healthy diet, as well as, uh, going towards no smoking and less alcohol usage, less use of junk food, and less of stress, and good sleep. Plus pharmacological therapy, which is only to be used for selected individuals, I have already mentioned, because pre-diabetes can be controlled with the help of simple lifestyle modifications. And the evidences have proven, and treatment and pharmacological therapies are only meant for few selected individuals, where maybe there are other high risk factors associated with. So with this, I would like to thank Dr. Ravikant and the whole organizing team for giving me this opportunity to be amongst you and present this topic. Thank you very much.
Like you all on the stage, Dr. Parul Sinha ma'am, Associate Professor Obs and Gynae.
Let's move ahead with the program. And the next session is going to be a very interesting session, and it is a live structural interventional workshop on cardiology. The chairpersons for the sessions are Dr. Tarun Maheshwari, Additional Professor, Anatomy, Dr. Mehak Lamba, Assistant Professor, Medicine, KZMU, Dr. Rupali Khanna ma'am, and Dr. Surendra Kumar Zangid, Assistant Professor, Department of Anesthesia. Dr. Surendra sir will be joining us from the cath lab. The speaker for our session is Professor G. Tram, Associate Professor, Department of Anesthesia.